MDM theory exam is going on in full swing, and I am sure that this course will be definitely helping you, and also is already helping you in your the preparation pathway that you are having right now. So today we'll be discussing about hematology and oncology in critical care domain, and I have been asked or assigned the topic of neutropenic sepsis in critical care. So this topic is something which we do not encounter on day-to-day basis. Like the topics or the subject that is more of like critical care domain, like any other clinical aspect of routine critical care practice. So that's why I tried to go through or visit or revisit the literature that is there in neutropenic sepsis, and I could not get very robust solid literature on neutropenic sepsis, and the literature is also not very recent. If I would say, there would not be more common literature related to this topic. Now the domain we will be discussing in these headings: definition, pathophysiology, risk factors, risk assessment, approach, management, and the prognosis, along with some of the difficult scenarios that we get when we suspect or we label our patient to be in the neutropenic sepsis. And this is a topic, this is a question. If you get it and if you answer it well, then I think it would be not less than 90% you will get in this particular question. Now, I would be starting with a clinical vignette so that you will be easy to start with how this type of scenario actually will be presented in your day-to-day clinical practice. Now, you are asked to admit a 51-year-old lady who received ablative chemotherapy and an allogenic bone marrow transplant 2 weeks ago for acute myeloid leukemia. Since the last 4 hours, she has become progressively more dyspneic in the ward. And when you attended this patient at the bedside, you found that this patient is somehow not able to maintain the oxygen saturation and is more and more dyspneic in last 4 hours. The chest X-ray done just few hours before, or which you could find at the bedside, is demonstrating a diffuse pulmonary infiltrates. On the initial observation, the GCS is 14 out of 15, temperature is 38.4 degrees centigrade, pulse rate is 140 per minute, with BP is in the low range 90 by 40, and respiratory rate is 35 per minute. Definitely this patient is hypoxic, and the nurse has already put on 10 liter per minute oxygen, with SpO2 is not touching 90%. Now, you just received a full blood count report that came this morning at the bedside, which says that hemoglobin is 6.8 gram per deciliter with WBC of hardly, you can see, 200 per microliter, and the platelets is again low, that is 39,000. So the peripheral blood smear is being commented upon with occasional teardrops, occasional elliptocytes, occasional lymphocytes, and neutrophils seen. So I hope everybody could get this type of clinical scenario. And when you are attending this as one of the senior most person, so definitely the thing that should be coming in your mind, that this person is suffering from neutropenic sepsis because of this post chemotherapy status due to the AML ablative chemotherapy. Now there are certain definitions you need to remember when you will be answering this type of question in your theory paper and also in your clinical exam. Febrile neutropenia, which is also named as neutropenic fever, is defined as a single temperature measurement more than 38.5 degrees centigrade, or sustained temperature more than equal to 38 degrees centigrade for more than 1 hour. So if you are getting the single temperature measurement, which would be 38.5, or you are getting the temperature to be more than equal to 38 degree for more than 1 hour. Now, in a patient with decreased absolute neutrophil count of either 500 per microliter, or 100 per microliter with a 1000 per microliter with a predicted nadir of 500 per microliter over the subsequent 48 hours. That means the ANC has to be less than 500. But if you are getting the ANC to be 1000 also, but it is in the decreasing trend, and you can like, expect very well your the neutrophil absolute neutrophil count of 500 over the subsequent 48 hours. So this is in short your definition about febrile neutropenia. Now there is a clue here. Neutropenia, they say febrile neutropenia, but most of the time you will not get a simple sharp rise of the temperature, because neutropenic patients, if they are with sepsis or severe sepsis, may not have a fever, like in the elderly population patients on corticosteroids. And we all know the fever needs one type of your immune response or inflammatory response, and when the patient is neutropenic, so it will not mount upon that response. Now, the incidence of febrile neutropenia or neutropenic sepsis is higher in patients who are receiving chemotherapy for hematologic malignancy compared to those treated for the solid tumors. So, like in this patient, when this patient is being treated with acute myeloid leukemia with ablative chemotherapy, so the chances of getting febrile neutropenia is more compared to the solid organ tumors. Now, we need to also understand the pathophysiology, why actually febrile neutropenia or neutropenic sepsis happens. The first more and foremost cause, or I would say the reason why the person would be going into neutropenic fever or neutropenic sepsis is due to primarily chemotherapy induced bone marrow suppression. And the effect is reduced neutrophil that would be weakening the body's immune response to the infections. So it is like, primarily this patient is getting the chemotherapy, and the chemotherapy is causing bone marrow suppression, and that would be resulting in reduced neutrophil or neutropenia, and that is the sole reason of patient's body's the immune response which is weakened. Now, the second one would be chemotherapy induced barrier disruption or the mucosal damage. Chemotherapy damages the mucosal linings like the GI tract. We all know that can disrupt the mucosal epithelial barrier, and that is causing more and more bacteria to enter to the bloodstream, and that will be the reason for your neutropenic sepsis. Third one would be all we all know that because of this limited neutrophil response, because of this neutropenia, the body is actually getting the one type of reduced response to the classic signs of infection. That means the patient will not be showing the typical, the hallmark features of the infection signs like redness, swelling, maybe fever, and that would be one of the reason why we as clinicians or the person as the observer will not be getting the first clue that yes, the patient will think that yes, I am not getting any type of sick the infections, and the clinician also will be confused that yes, this patient is not having typical signs of sepsis, and will miss the classical the trajectory, and that would be the reason when we will be confused that our patient is completely all right. So that is one of the reason also to get the patient at a later stage with frank sepsis because of this neutropenia. Now, the common pathogens, the responsible for neutropenic sepsis, gram-positive staph, gram-negative pseudomonas, and also fungal infections like Candida and Aspergillus. They're common in prolonged neutropenia. There will be also, despite this low neutrophil, the cytokines release will be occurring, and that can lead to the sepsis. And as a result, what will happen? The severe systemic inflammation, and the patient will be landing up in the multi-organ dysfunction and shock. So this is in short the pathophysiology which is mainly happening because of this low neutrophil count, which is our the barrier for tackling the infection. Now, we need to have some infection risk assessment that this person is more prone to get infection, this person is less prone to get infection. And that can be happening if you know that the severe neutropenia is one of the strongest risk factor if you are actually getting the neutrophil count to be not 500 also, if it would be less than 100 cells per microliter for more than 7 days, this is one of the high risk category of getting neutropenic sepsis. Also, there will be some of the other risk category patients like acute leukemia induction therapy or allogenic hematopoietic stem cell therapy when the patient will be having profound and prolonged neutropenia. There is a difference between profound and the duration also would be for long time. One would be the absolute number. If it is less than 500, less than 100, definitely the patient is in the high risk category. But if the patient will be also having that neutropenia for almost 7 days or more than 7 days, so that is again one of the high risk category that this patient will be developing some or other infection. Now, lower risk, it is lymphoma or autologous hematopoietic, the stem cell therapy and transplantation. There would be short neutropenia duration and the intact neutrophil function between therapy. So when the patient is subjected to the therapies like chemotherapy, so it would be during that time the neutrophil count would be low. But once that therapy is over, the neutrophil would be regaining the function, and that would be again able to protect the person from getting some new infection. So you have to understand that there is some high risk category and there would be some low risk category. Now, the risk factors also can be divided into host factor, treatment related factor. Now, the host factor, it would be the age. We all know advanced age or extremes of age, it would be more prone to get neutropenic sepsis. The patient is nutritionally very poor status. Functional status is very poor because of the previous comorbidities, the frail status of the person. If the person is having or the patient is having indwelling catheters, number of indwelling catheters are more, and also the patient is having hepatic or renal comorbidity. So these are the host factor that can predispose the person to get some new infection. Now there would be some treatment related factors as well, like allogenic hematopoietic the transplantation. Now higher risk infection because of the factors like HLA mismatch, myeloablative conditioning, graft versus host disease treatment, or some or other donor factors, because donor is here also the treatment related factor. So these are the things that would be determining that yes, this person or this patient is more prone to get a neutropenic sepsis. Host factors, treatment related factors. Now, there are certain risk scoring systems in the examination. They may ask you, or you should remember the names. One is the Multinational Association for Supportive Care in Cancer, MASCC, risk index score. And believe me, this is the characteristic burden of the illness: no hypertension, no COPD, solid tumor or hematologic malignancy with no previous fungal infection, no dehydration, outpatient status, age less than 60. So this is one of the score where if it would be less than 21, then you are actually having high risk for getting neutropenic sepsis, because all these things are actually written in a better way. So age less than 60, it is 2. So you will be, if your person is getting neutropenic sepsis in these patients, so the score would be less here. Now there is another score which is CISNE score. CIENE score, that is clinical index of stable febrile neutropenia. So you have to remember this type of long full form. But yes, if you are getting the examination question, so you have to at least mention this mask risk index score and this CISNE score, and you can remember these the society specific scores. They have made it Eastern Cooperative Oncology Group performance status more than equal to 2. If the score is, then 2 points. Stress induced hyperglycemia 2, COPD 1, Chronic cardiovascular disease 1. Mucositis of grade more than equal to 2, 1, and monocyte less than 200 is equal to 1. Now in this, if your mass score less than 21, it indicates high risk, greater morbidity and mortality. While CIS NE score more than equal to 3 classifies as high risk for unfavorable outcomes. Just remember this, less than 21, more than equal to 3. Now, there are certain infective organisms we need to remember when we are dealing with the typical case of neutropenic sepsis. That primary concern would be, as usual, you all know GNB, CNS, MSSA, Streptococcus viridans. There would be also like the role of resistant organisms like MRSA, VRE, ESBL, Pseudomonas, Strenotopomonas, Acinetobacter, and also fungal infection. Sometimes you will also get some viral infections, CMV, EBV. So you need to also remember. Nowadays, GPC is somehow more predominant due to we are using left, right, center, or any patient coming with in our emergency department or ICU, we start with more of gram negative or like the bacteria. So that would be the one reason the gram negative infection will not be that high in the onco critical care unit. Rather, the GPC will be more predominant because of suppression of the gram negative infections. And also these patients or with long-term vascular access devices. So that is also one of the reason you will get more of GPC. And any patient with neutropenia, the oncologist or the primary physician will start with fluoroquinolone prophylaxis. So these are also some of the reasons why you will get GPC more predominant. Now the antibiotic choice that has to be discussed in these formats. One is the rationale. Why we need to start with antibiotics for this neutropenic sepsis? We need to cover the likely causative organism. Though we'll not always get the culture report in the very first instance, but we need to cover the likely causative organisms. Now, this could be due to Pseudomonas aeruginosa, which occurs relatively infrequently in certain centers. But if your patient is having Pseudomonas aeruginosa, definitely the morbidity and mortality would be very high. So better to cover with the empirical regime that would be against these Pseudomonas. Now, the choice of antimicrobials will also depend upon your local susceptibility patterns and also patient's risk of infection with a multi-drug resistant organisms. Now, therapy should be reviewed when you are getting the causative organism and also the susceptibilities are also known. Prophylaxis should not be used. Rather, it should be told as empiric therapy that we are giving. Now, the first line antibiotic in any patient who is presented with neutropenic sepsis, you can start with peptide 4.5, 8 early or 6 early if patient is having like septic shock and severely sick, or cefepime 2 gram IV 8 early or ceftazidime 2 gram IV 8 early. Now, we need to also consider adding gentamicin 4 to 7 milligram per kilogram ideal body weight if you know that your local microbiological data is suggesting there is risk of resistance to the above antibiotic peptide, cefepime and ceftazidime, and the patient is critically sick with septic shock. Now you should also consider adding vancomycin for suspected MRSA. If you are thinking your patient is having severe sepsis or septic shock, is known to be colonized with MRSA. There would be many instances your patient will be colonized, or you think that this patient is colonized with MRSA. And also, there is a clinical evidence of a catheter related infection with high incidence in your unit of MRSA infection. And when the patient is still having fever, despite you have started antibiotic on the very first instance, but the fever is persisting at 48 hours, so you need to add or think to add vancomycin. Now, change to meropenem if your ICU is suspected to have more of ESBL organism. Add antifungal, for example, voriconazole if you are thinking that there is fungal infection in the form of candidiasis, aspergillosis or mucormycosis, and fever is persisting, in the high risk category of patients beyond 4 days of antibacterial therapy. Along with these antibiotics, you should also add cotrimoxazole for suspected pneumocystis jirovecii pneumonia. Also think about your HSV or CAV infection. I have already given a hint. That is also one of the organism for your the neutropenic sepsis. When you have to add acyclovir or ganciclovir or the other newer antiviral therapy, and always you should be thinking to get the help from the ID, infectious disease. Now, there would be a situation when you have to think about de-escalation of antibiotic. When you have started the antibiotic empirically, so you have to also think about that minimizing the antibiotic exposure in stable patients without increasing the risk. So that would be when you think from IV broad spectrum antibiotic to prophylactic or stopic antibiotic before your absolute neutrophil count recovery. Because your neutrophil count will take some time to come to the normal range. So if you are thinking that my patient is not having any type of sepsis, rather if I would be starting or continuing with this high antibiotics for a long time, I may get the antibiotic resistance. So in that situation, you have to think about de-escalating the antibiotic from IV to the oral form. Now, the guidelines as per the various the associations and societies who are dealing with this the chemotherapy or radiotherapy or the tumor the CAR therapy induced febrile neutropenia, as per the European Society guideline, de-escalate if your patient is stable for 72 to 96 hours, febrile for 48 hours, regardless of the absolute neutrophil count. You just wait for maybe 2 days febrile and stable for 3 to 4 days. Now, as per the ESMO guideline, it would be more conservative because there are many guidelines you have to think about. They preferably keep for 5 to 7 days the antibiotics in some high risk cases. Then, if you are still the patient is febrile, then you can stop it or change to oral form. Now, there is another guideline which would be saying option to discontinue in stable febrile patients without specific duration. I'm not going into the detailed the guideline analysis because it would not be very prudent in your exams, but rather you can just think about if the patient is stable for minimum 3 to 4 days, you can think about changing from IV to oral antibiotic. Now, how will you assess any patient with febrile neutropenia or neutropenic sepsis? First of all, history and examination. You should always have a structure. Now, suspect neutropenia in any hematology or oncology patient who has received chemotherapy, which is oral or IV, within last 14 days, or patient has a history of recurrent neutropenia. This is the first. From the history only, you will get that yes, my patient is in neutropenic sepsis. Now you should assess from head to toe, something like upper respiratory tract for otitis media or sinusitis, oropharynx for the dental abscess or mucositis. Then come to the lower respiratory tract for signs of pneumonia. Here you can think about PJP pneumonia. That would be presented as cough, tachypnea, hypoxia, interstitial infiltrates on the chest X-ray. Now come to the abdomen. You will say may get the signs of Clostridium difficile colitis, generalized abdominal tenderness, or typhlitis, which is tenderness over the cecum. Now, then you should be also examining the skin for cellulitis or some other vesicular lesions. Perineal or perianal area for anal fissure, cellulitis, or abscess. Then you should also think about the central venous access devices for signs of tunnel or exit site infection, and also sign of anemia and thrombocytopenia that would be inherent in this type of neutropenic sepsis. Do not perform a rectal examination without a proper indication because that would be exposing the patient for getting the new infection because patient is completely immunocompromised at this stage. Now, there has to be investigation. What are the investigation you will order? You have to take blood culture from peripheral site in addition to each lumen of the all pre-existing intravascular devices before administering antibiotic. The full blood count, the urine examination, LFT, CRP, lactate, And if clinically indicated, you have to think about chest X-ray, nasal swab for respiratory virus PCR, sputum, the culture sensitivity, stool culture, viral studies, Clostridium difficile toxin assay if the patient has been exposed with antibiotics, bacterial swab for the skin as well as vascular access site, mouth lesion, viral swab of the vesicular lesions, mouth ulcers for HSV or varicella zoster virus PCR. If you are having or getting neurologic symptoms, you should think about considering for CT brain or LP, CT chest and bronchoalveolar lavage for suspected pulmonary infection, and CT pan scan. If you are still not getting the source of sepsis, you should think about going for a complete body CT scan and echocardiography for endocarditis. Now, how will you manage this type of patients? Immediate resuscitation, ABC, address life threats such as septic shock, fluid, vasopressor, invasive hemodynamic monitoring, early antibiotic within first, like I would say 30 minutes or so. At least you should be completing in first hour. Early source identification and control, discuss with hematology before. This is one of the clue also. If the patient is having some or other device, before removing you should also consult the primary consultant or the consultant who has shifted the patient in your unit, but he has or she has put that for some or other reason, because that may be one of the precious site or device. So if you will be removing it without consulting, maybe the patient will be again exposed to some or other more invasive, like the procedure that is not actual accepted at that point of time. So you have to think about CLAPSI, port pocket site infection, endocarditis, septic thrombosis, septic shock, tunnel infection, or persistence of the bloodstream infection even after 72 hours of appropriate antibiotic therapy. Now, environmental precautions, that is also one of the thing. As a clinician, as an intensivist, you should be thinking about protective isolation, hand hygiene, full barrier precaution for this type of patients. Now, there is a role of GM-CSF. We all know granulocyte, monocyte, colony stimulating factor. What is the role? Just like one slide about this. It increases the neutrophil count, reduces the rate of serious infections, decreases the mortality in bone marrow transplant or dose intensive chemotherapy, but don't use in acute leukemia because it may stimulate the leukemic clone, because you are giving to like no stimulate the colony stimulating, the name is colony stimulating factor, but we do not want the stimulation of the wrong colony. So that's why in acute leukemia, don't use GM-CSF. That is one of the clue. Now, siege once your neutrophils have like no gone up to 1000. So sometimes we use it in the range of 2000, 2500 also. But in case when the patient is in oncocritical care and received chemotherapy, so the target, the threshold should be 1000. There have to be also sometimes adverse reactions to the GM-CSF in the form of rash, injection site pain, bone pain, influenza-like symptoms. And simultaneously, you have to continue with supportive care, monitoring, and when the patient is stable enough, you should think about for the proper disposition. Now, there would be this type of the flow chart I would share with you. A patient with febrile neutropenia in hematologic malignancy. Now, you should go for assessment of the infection. I have already explained about the history, physical examination, routine lab test, the blood culture, symptom directed workup. Now, you have to again divide whether this patient is in the high risk category or in the low risk category as per this mask or CISNE score. Now, if it is high risk, admit for inpatient. Febrile neutropenia management workup should be there. You should empirically start anti-pseudomonal beta-lactam antibiotics, then reassess, and you should also think about adding vancomycin. I have already discussed about the conditions where you should be adding vancomycin. And if the patient is afebrile after you have started these antibiotics as well as resuscitation, no infection identified, then you should be considering de-escalating your the antibiotic, which would be fluorochloral prophylaxis or stopping the empirical antibiotic. But if you are getting the microbiologically identified infection, your treatment should be targeted now based on culture and susceptibility result. Now, If patient continues to be febrile, you should be continuing with your empiric anti-pseudomonal antibiotic, consider for more imaging and consider fungal workup. But in the other category, which is a low risk category, you should consider outpatient febrile neutropenia management. Now, the prognosis, general prognosis is directly proportional to the number of organs involved as opposed to the underlying malignancy, and outcomes following ICU admission is not as dismal. You should not be like always in a very much negative sense or attitude. Rather, these patients, if treated well, they would be responding well. And factors improving ICU survival, if you better select the patient category, early admission before the patient is landing off in MODS, overall improved prognosis in hematologic and solid malignancy. If you are like going with non-invasive ventilation, we all know this is one of the grade A, class A indication of like no NIV, patient with immunocompromised state, respiratory failure. Use of diagnostic bronchoscopy, if you do it, get the organism, treat it well, the patient will respond well, and also improve survival rate in the septic shock. Now, there is one or two difficult scenario I want to highlight before I will be concluding. One is persistent febrile neutropenia. What do you mean by persistent febrile neutropenia? The definition is ongoing fever in neutropenic patients without an identified infection. You have not identified the exact etiology, but the patient is still having fever in neutropenia state. The risk is hematologic malignancy patients are at high risk for the invasive infections. So what you have to do, you have to assess well, you have to go for the differential diagnosis, like the discussion, reevaluate for the the viral, fungal, and bacterial sources. If the patient is still continuing to have hemodynamic instability, you have to repeat the culture again, send the pan culture, expand the antibiotic, and consider taking ID consultation. And how will you there are certain clues. Do not broaden the antibiotics solely on the fever basis. You have to get some clue that yes, this patient having some or other infection, and you have to think about fungal thing, the infection in high risk category like leukemia, hematopoietic stem cell transplantation, and there should be, if your patient is not responding after 4 days of empirical therapy, as I have shown in the first few slides. Now, there is another last difficult scenario when your patient is actually you have started with card therapy and then you are getting your patient to be with febrile neutropenia. So you know the etiology. So the background would be card therapy used for refractory lymphoma, myeloma, or ALL, and we all know the risk factors. Now, in this, the lymphodepleting chemotherapy, prolonged cytopenia, immunosuppression is the cause, and you have to think about another thing, that is cytokine release syndrome. Sometimes this would be the normal response of the CAR therapy. So you have to wait for a few days with your supportive therapy and the patient will be improving gradually. So maybe the diagnostic challenge would be how will you differentiate between cytokine release syndrome and sepsis, because the clinical feature would be more or less similar with the typical sepsis, fever, hypotension, hypoxia. The standard practice, you should continue with empiric anti-pseudomonal antibiotics, and also there would be always a debate, the infections and the prophylaxis, the proper treatment, but you should be use your clinical judgment. There is no clear consensus that you should not use this antibiotic at this stage or you should use antibiotic at this stage. So with this, I would be ending up, and thank you very much for your patient listening. Any questions or anything that anyone wants to clarify? This is a topic. If you know this much, you will get 90 to 100% of your theory mark. And also in practical, sometimes you will definitely get a scenario where you have been asked to answer some of the difficult scenarios when you will be going for the barrier precaution. What would be the role of prophylactic antibiotic? What are the antibiotic the regimes that you know? What is the infection risk assessment? And in some of these the clinical situation where actually there is no history of oncology. Yes, role of biomarkers, Dr. Jagan. If you are no, there is one literature that is showing if you are getting your CRP more than 80, that would be more predictive of that this patient is going into the sepsis. In the literature, in the guideline also they have mentioned. But as a whole, the standard biomarkers that we use for our routine infection risk assessment, only limitation or flip side would be these biomarkers would not be the only way, because they would be taking some time, because it's like we all know the immunosuppression is the etiology here. So the biomarkers trained would be rather one of the biggest help that we can get from our clinical as well as the lab finding. No exact specific biomarker for the febrile neutropenia, but yes, the battery of biomarkers that we all know in the form of CRP, procalcitonin, lactate, and some or other newer biomarkers. Okay, perfect. So thank you very much, and I request Dr. Darshan to please carry forward.
Thank you, sir. Yes. I think so. The most common questions, and they have to focus on, like you told already, is to look at the definitions per se. So,
Yes,
persistent
yes,
febrile neutropenia, definition of febrile neutropenia, and the scoring system, both the mask and Sisney scores.
yeah,
So, biomarkers is something like you told, it is basically for treatment responses. And
yes,
the whole takeaway is there's no standard guidelines that they have to follow. Local antibiograms and the site of sepsis should be identified at the earliest, and then they have to carry forward, which is similar to any other septic parameter. I think so.
yeah.
That is a very nice topic you covered. So thank you.
Thank you. Thank you. Just before we will be starting the next one. Anyone how can like one calculate the absolute neutrophil count? Because that is one of the practical
Correct.
questions normally we get. So anyone who can give us no, you can unmute and no tell, or you
All
can post in the chat box. Yeah, Dr.
polymorphs,
Dinesh. Yeah, please tell me.
polymorphs plus bands we have to add.
Okay. So what
And
are the things you need? You need the WBC count. You
then
need the percentage of neutrophils. Sometimes in the lab report, you get as segmented neutrophil, or they are also named as also segs, segmental from that segs, and also band form, band cells, the immature neutrophil. So what is the formula for this? Absolute neutrophil count. You are having WBC count. If your WBC is 5,000, with 60% neutrophil and 5% band, then what is the absolute neutrophil count?
we have to add them together and calculate its score. We
So
have to
just
take the bands also for
yeah, you,
calculate.
you tell me, I am calculating. This is
65
just
5,000.
so 60 plus 5. So it would be 65, and that 5,000 into 65%. So absolute neutrophil count would be 3250. So that is the formula. So if it is below 500 in this way, it would be indicating for your neutropenic sepsis, or the patient is in higher risk for the infections. So you should calculate at the bedside. Sometimes the examiner in the practical bedside exam, they would be giving you this type of numbers, and they would be expecting that you will be immediately getting the ANC at that time. Okay. Thank you very much.
So, shall I start, sir? Yes.
Yeah, please, please, please.
Is my screen visible?
Yes, yes, it's visible. Please
Yes.
make it to the, yes,
Yes.
perfect.
Okay, sir. So, good evening, everyone. So, we'll go ahead with the next topic. We'll be starting another interesting topic in hematology, that is heparin-induced thrombocytopenia and thrombosis, which is again a clinical scenario, like most of us will be facing this. So, coming to the outline, I'll be going under the following headlines: the definition, pathophysiology, clinical features, diagnosis, management, and newer modalities. From the previous year question banks, this has been asked in multiple exams as a short note question, be it as a sub question for 5 marks or sometimes even as an adverse drug reaction question. Okay. So most of the things which I've been presenting in this particular topic would be taken from this particular review journal, which actually had very good cartoons that I couldn't have done it myself. So I'm going ahead with this. Along with this, I've referred to a few other articles. So this has been published roughly a year ago. So I thought it will give us the best, information available. So heparin-induced thrombocytopenia, the actual full form is heparin-induced thrombocytopenia and thrombosis. Okay, it is an immune-mediated adverse drug event to heparin that results in both thrombocytopenia and a potentially catastrophic thrombosis. So we need to remember that there is thrombocytopenia, and despite that, there would be an occurrence of catastrophic thrombosis in which the inciting event is the exposure to heparin. The incidence which they have reported is roughly 1 in 5,000, 1,500 hospitalizations, and mostly it is associated with major surgeries like cardiac surgeries and with the use of unfractionated heparin as compared to low molecular weight heparin. But you have to remember both unfractionated as well as low molecular weight heparin has been associated with the occurrence of HIT. So the only thing which they have noticed is the incidence would be coming down if the exposure to usage of heparin was shorter. Okay, usually less than 5 days. So coming to the pathophysiology of heparin-induced thrombocytopenia and thrombosis, what usually happens is heparin, which is usually available for any prophylactic measures or therapeutic anticoagulation if we are using it, it is usually a negatively charged polysaccharide chain. Okay, so when this actually activates an immune response, it is usually to the platelet factor 4, which is usually present on the megakaryocytes. This usually causes release of alpha granules from the activated platelets. So when this platelet factor 4 and heparin, they form a complex, okay? And this activates the cascade of events which usually happens. So how does this anti-platelet 4 and heparin antibody cause HIT? That is what we need to see, okay? So I've already mentioned there is both thrombocytopenia and thrombosis. So the question all of us would be thinking is, if there is thrombocytopenia, how is that thrombosis happening, right? So this is the pathophysiology. What usually happens is when the platelet gets activated by the antibodies, there will be an activation of both the neutrophils and the monocytes. So what happens when the monocytes get activated is it releases a lot of toxic granules, microparticles, as well as tissue factors. Okay, so we all know when there is a tissue factor release, it always goes on to a cascading phenomenon, causing the occurrence of a thrombosis by changing the subendothelial or the endothelial milieu. Correct. Similarly, when the neutrophil gets activated, what happens is it engages in the release of a lot of red blood cells, platelet factor 4, von Willebrand factors, and a lot of other molecules and moieties, which causes consumption. Here, there will be drop in platelet count, but here there will be activation of a thrombotic phenomenon. So whatever platelet is left over ends up forming a clot here. Okay, so this is how HITT actually occurs. Okay, that is heparin-induced thrombocytopenia and thrombosis. So in the lower part, you can see how thrombocytopenia happens because of consumption. In the upper part, because of activation of monocytes and release of tissue factors acting on the endothelial cell, it triggers a prothrombotic state leading to formation of a thrombus. Okay, so one more thing is notice that most of the times it doesn't mean that all the antibodies which are caused due to the activation of platelet factor 4 release causes thrombosis. The only IgG antibodies are known to have caused HIT, okay? But if you take IgM and IgA antibodies, the occurrence of this is usually less. Along with that, what they have also noticed is ultra large molecule complexes of the platelet factor 4 and heparin complex is the one which is having an increased immunogenicity, and this can cause HIT. Okay, if there are smaller complexes, probably they might not trigger the immune reaction leading to formation of thrombosis or consumptive megakaryocyte. Okay, am I clear? So if this is too much to remember, this is what you can, simply remember in your exams for simplicity's sakes. Remember, there will be release of alpha granules because of the activation of the platelets and the platelet factor 4. This platelet factor 4 and heparin usually form a complex which acts on the FC receptors on the platelet. Okay, this again causes a cascading effect and causes both thrombocytopenia as well as clot. This is what is the basic outline for HET. Okay. So what are the signs and symptoms? Usually thrombocytopenia is defined by a hallmark pattern of more than 50% of the drop in platelet count. Absolute numbers don't matter. I'll be coming to that in the next slides. Okay. So what you need to remember is there is a drastic fall in the platelet count. There will be a lot of thrombotic events happening. It can be associated with the deep venous thrombosis, or it can also be associated with PE, sometimes even with cerebral or dural venous thrombosis. There have been reports suggesting the occurrence of hemorrhages. It can be either in the adrenal glands or generally anywhere in the body, from ranging from the GI tract, the brain, and the retroperitoneum. Okay, so this is usually the bleeding is not classically associated with it. What usually is seen as the thrombotic phenomenon. The other smaller or the lesser known signs and symptoms are the occurrence of venous gangrene, which is usually in a co-use of both vitamin K antagonists associated with the use of heparin in the acute event, like in a case of a surgical patient, or else in an anaphylaxis type of a reaction, which usually happens especially in the plastic surgery settings. Okay, so these are other places where patients can be prone to a development of heparin-induced thrombocytopenia and thrombosis. If you see, there is a broad classification. They say there are two types of hit: type 1 hit and type 2 hit. Okay, type 1 hit, there is no ISTH definitions for type 1 and type 2. These are only for examples and understanding sake. The type 1 hit is usually self correcting mechanism. It usually happens to the first exposure of heparin, and it is usually an anaphylaxis type of a reaction. So it automatically subsides by itself on day 2 to 3. So it does not fit into the classical definition for hit. The type 2 hit is what we discuss. Okay. So the clinical manifestations, like I was already mentioning, the majority is thrombotic phenomena, roughly up to 60%. Bleeding is as low as 6.2%. But what we need to understand is whenever the patient comes to the hospital and develops it, the morbidity associated with this is very high, because there have been incidents of increased amputations or loss of limb, increased mortality, and increased length of stay associated with HIT. Okay, so rarely this can also be intertwined with the occurrence of DIC or necrotizing skin lesions as well. Okay. So how do we approach a patient who comes to us with a probability of hit? So you have a patient in the hospital, probably in a ward-like setting or in the ICU or HDU. So you get a platelet count, probably the platelet has dropped to 20,000, and that's the reason they want to shift the patient from the ward to the ICU. So this is basically an approach to thrombocytopenia workup, wherein you have to look at all the possibilities of the cause, whether it is in the occurrence of production, or it is in sequestration, or it is in the lysis type of situation. So it is basic approach to thrombocytopenia is what you need to start with, and then look at the 40 score. If at all you're thinking of a possibility of heparin, wherein you see that the patient had received heparin for any reason, it might be, be it DVT prophylaxis or intraoperative use. Okay, so the 40 score usually consists of four important parameters. As the name suggests itself, it includes four T's, that is thrombocytopenia, timing of the platelet count or platelet count fall, occurrence of thrombosis or sequelae, and other causes of thrombocytopenia. The T in other is the fourth T. Okay, so usually based on this and the the depth of the problem associated with each parameter, they are given a score of either 2, 1, or 0 points. Okay, and then based on this, they will be classified as high, intermediate, and low risk for the occurrence of HITT, that is heparin-induced thrombocytopenia and thrombosis. So coming to the first T, that is thrombocytopenia. So there are three scores that I've already mentioned, that is 0, 1, and 2, right? So what is important here is, I'm again stressing, as I've already previously mentioned, it is not the absolute number of platelets or the count of platelet that is important. It is the fall in the platelet which is necessary to be ascertained. That is, the platelet fall will be usually more than 50%, and the nadir roughly would be around 20,000 cells. Okay, so that is what you need to look into it. So if you have any such event, then the patient gets a score of 2. If the platelet fall is between 30 to 50% and the nadir falls between 10 and 19,000, then the patient receives a score of 1. And if the platelet fall nadir is less than 30% or 10,000 cells, then they receive a score of 0. Coming to the second T, that is timing of the platelet fall. Usually, by definition, HITT, the fall starts between day 5 and day 10. So this is something that the timing is extremely clear. And usually the fall starts more or less within 1 day, but there have been reports of HITT or HIT occurring in the in patients who have had an exposure to the heparin as previously as around 30 days prior to the onset of the event. If the fall does not fit into any of these criteria, that is between 5 to 10 days, or it is more than 30 days in the previous exposure, they get a score of 1. Or else it is remote heparin use is what you can remember it as. If the patient has remote heparin use, then they get a score of 1. Okay. If the fall starts less than 4 days, probability of HITT is less. So that is why they get a score of 0. So this is what I want you to understand what I mean by the drop in platelet count. Okay. The platelet drop is what you usually want to know. Okay. The absolute numbers doesn't matter. And as I've already told you, the recent exposure, what matters. Remote use of heparin may or may not be associated with the occurrence of heparin-induced thrombocytopenia. Okay. So thrombosis and other sequelae is the third T, correct? This is the most important one, because they have been attributed to an occurrence of 30 to 60% of the clinical symptoms associated with HIT. So any new thrombosis, be it skin necrosis or any major thrombosis in the body, gets a score of 2. If the patient is having erythematous lesion, probably you might think it as an ecchymotic lesion. Probably these things get a score of 1. Okay. If none of these are present, the thing would be 0. So what we need to understand is probably these skin lesions which we attribute to ecchymosis due to thrombocytopenia should be clearly evaluated and ruled out that this is not the occurrence of HIT in such patients. Okay. So the other or the last T is other causes of thrombocytopenia, which usually here we need to rule out whether there is an attributable cause to heparin. So other possible causes, be it for decreased production or increased sequestration, is ruled out. In such cases, you have to rule out the other causes of thrombocytopenia. So based on these 4 parameters, based on the scoring of 0, 1, and 2 for those scorings, usually if the score is more than or equal to 6, the probability of hit is around 64%. If it is between 4 and 5, it is intermediate. And if it is less than 3, it is a low risk for or low probability for HITT. So is this the only score that is known? No, there is another scoring tool which has been used, and that is called as the HIT, or the heparin-induced thrombocytopenia expert probability score. If you see at the individual parameters, that contains 8 parameters, which is usually cumbersome for us to recall. Okay, and if you see it much closely, it usually contains the same thing that it's already mentioned in the 4T score, but the individual weightages would be more here. Okay, so it's not necessary for you to remember both. 4T score is more than enough. Okay, the only advantage here is they have given a lot of weightage for other causes. That is the fourth one. Okay, so that is something which is not present in the 4T score. So coming to the lab diagnosis of heparin-induced thrombocytopenia and thrombosis, usually whenever you have the patient coming to you with these 2 parameters of thrombocytopenia and thrombosis, and with a recent history of exposure to heparin, then you have the suspicion of HIT being higher. The first and foremost thing is stop heparin, if at all heparin is going on. Okay. And you need to start this patient on an alternate anticoagulation therapy immediately. I'm repeating myself. If at all you have a laboratory diagnosis of suspicion of HITT, the guidelines say stop heparin immediately and start the patient on an alternative anticoagulation therapy immediately, despite the platelet count parameters. Okay, because the risk of thrombosis in such cases would be high. And coming to the lab diagnosis of HIT, it is usually divided into 2 parameters, that is immunoassays and functional assays. Okay, So the first immunoassay, which is more often done in most of the laboratories and it is widely available, it is called the enzyme immunoassay. Okay. So what usually they do is they use a plate which is well coated with multimers of platelet factor 4 and heparin complex. Okay. And this is usually subjected to the patient's serum or plasma, which contains the anti-platelet factor 4 heparin antibodies. Okay. So this is helped to bind the complex, which is multimer, which is already present in the plate. What they do after this is they tag an anti-human antibody that is usually added to these antiplatelet factor 4 and heparin to get the color change. So based on the color change, they give a grading to this. Okay. What we need to know, the grading is between 1 and 4. Anything is more than 0.6 by the numericals or between 3 and 4 is considered to be a positive test for, or positive enzyme immunoassay. So I'll repeat myself. Okay. So you have a plate. Okay. This is what you just have to remember. This is a plate. It has multimers of, platelet factor 4 and heparin, which is already present in all the 4 plates. Okay. So for this, the patient's serum is added everywhere. Okay. Along with this, they tag an anti-human antibody, which is binds against the anti-platelet factor 4 heparin antibodies. So based on the concentration of the antibodies, there would be a color change which happens. And based on the color change, they can give you a reading. A reading of more than 0.6 or between the score of 3 and 4 is considered to be positive. Okay. So this one test is actually sufficient enough to let us know that this patient has heparin-induced thrombocytopenia. If it is negative, usually it rules out a hit, but this is not the gold standard. Okay. So the only thing is this is widely available, and that's the reason it can help us understand better and get a easier or faster result. So other immunoassays, as I've told you earlier, that the antibodies which are usually tested as the IgG type of antibodies, right? So there are other things like the latex immunoturbidometric assay, which usually tests for IgA and IgM along with IgG, and lateral flow immunoassay, particle gel immunoassay, chemiluminescence assays are the other things. You just can remember these names. Specific details of these are not necessary for us to remember. Okay. So coming to functional assay, so you have done the enzyme assay. So after the enzyme assay or the immunoassay, you need to do a functional assay. So what do I mean by a functional assay? So functional assay is something which actually triggers an event. Okay. So the most important functional assay which helps us diagnose HITT, or else it's the gold standard for the diagnosis, is the carbon 14 labeled serotonin release assay. Okay. So it usually is used to determine anti-platelet factor 4 heparin antibodies, which are pathogenic. That is, which are activating the platelets. Okay, or else which trigger the cascading phenomenon. Okay, the sensitivity and specificity of this carbon 14 labeled SRA or the serotonin release assay is very high, approximately around 95%. Okay, so it is a comparative assay. Usually what happens is patient serum and the donor platelets are taken. Okay. One important prerequisite of a serotonin release assay is the patient should not have any effect of residual heparin, which is being present when you do this test result. Okay. So if you're doing this test, you should make sure that the usual duration of action of heparin has been offset or it's removed. So you should make sure that is there because it can hamper this. Because what we usually do in SRA is use 2 doses of heparin. Usually that is the therapeutic dose between 0.1 to 0.3 international units and a high dose heparin that is 100 international units per ml. Okay. Using these two, we look at the possibility of the release of serotonin because of PF4 and heparin antibodies. So in the therapeutic dose, these antibodies serotonin, which is usually captured by SRA. In the higher dose, as I've told you before, what happens is the platelet factor 4 heparin antibodies do not trigger the activation of the cascade, or else the immune response, because of which there will be no serotonin release. Okay, I'm repeating again, only if there is serotonin release in the therapeutic range of heparin, then it is considered to be a positive result. If positivity even with the high dose heparin, then it is a false report, okay, or it comes as an indeterminate report. So at this time, probably you might have to check for recent use of heparin, etc., because those can become a confounder. Okay. So what happens? So all of us might be thinking at this particular time, why that both the things are heparin, then why only in therapeutic dose you'll see a serotonin release, but why in case of high dose of heparin you're not going to see? What usually happens is at high doses, heparin, that is the multimolecular hit antigen which is present, right? It does not trigger the release of serotonin. But whereas if it is present in the lower composition, you can see the multimers here. Okay, so this doesn't activate the platelet, and then this prevents the release of serotonin in higher concentrations. Because of this, the IgG doesn't bind through that itself. So because it doesn't bind here, there will be no cascading phenomenon causing the release of serotonin. Am I clear? So the other functional assays which are present are the HIPAA assay, that is the heparin-induced platelet activation assay, and the p-selectin expression assay. Okay, so the HIPAA test is usually a visual turbidity test. So they usually add an reagent, and based on the reagent, they check what happens to the turbidity. If the turbidity increases, that means say there is increased presence of immunoglobulins, which might be platelet factor 4 heparin antibodies. That usually gives a functional assessment of the possibility of hit. In a p-selectin expression, usually the p-selectin, the cluster of differentiation 62 parameter is usually used. And based on a flow cytometry test, they come to a diagnosis of possibility of hit. Okay, just remember the names SEPA and p-selectin. If you can, it's good. But carbon 14 labeled serotonin release assay, something that you need to know because it's the gold standard test for diagnosis of HITT. So you have two things right now. You have the enzyme immunoassay test and the 4T score. So based on these two tests, what they did is they checked out if it gives, just by using these two tests, and can we avoid a functional assay. What usually happens is functional assay like the carbon 14 labeled serotonin release assay is having a longer turnaround time because it's not routinely available. So what they also looked at is it possible by the use of only enzyme immunoassay, optical density, as well as 4T score, can we get the possibility of a HITT diagnosis? So individually, when they used either EIA or 4T score, the high probability and intermediate probability was between 14% and 64% for 4T score. And based on the EIA OD, it ranges, I told you, less than 0.6, unlikely. Anything more than 0.6, probability increases. If you see more than 1.5, there is a 50% chance of a probability of hit, and 2 plus is definitely 90%. Okay. So if you combine these two scores, what usually happened is the probability of the diagnosis increased. So just by having a score between 6 to 8 and getting an EI optical density of 2 plus, it's more than sufficient to get a 99% result for the diagnosis of HITT. So coming to the phases of management. So we told you by diagnosis, I was telling you earlier, usually 5 days is necessary by timing criteria for the diagnosis of HIT. So at that particular time, your patient might already be recovering, or probably you might have stopped heparin when the platelet dropped less than 1 lakh or 75,000, depending on whatever the condition of the patient is, or you might be seeing some amount of bleeding. So based on all of these parameters, you might have stopped heparin. So you need to know where the patient lies or what is the spectrum of the disease at that particular time, correct? So again, you have these four parameters which come into picture. That is the platelet count, functional assay, enzyme immunoassay, and thrombosis risk. If you find that there is a decreased platelet count, functional assay and the enzyme immunoassay being positive, and you have found an increased risk of thrombosis, then the patient is an active or acute heparin-induced thrombocytopenia. If one of these things changes, most likely what would have usually happen is if it's not a very severe type of a hit, the platelet would have started to improve or returning to normalcy, or one of these parameters would have started to become better. So usually if this is happening, so the patient can range between a acute hit or a possibility of a remote hit. Okay. The subacute A and B depends on the functional assay and the enzyme immunoassay. Okay. So what you need to understand is whether the patient is an acute hit or the patient is in a suspected hit. On the suspected hit, what will usually happen is you just have the platelet count based on which you will still be running these tests. So you don't know. So in acute hit, you know that these you already have a diagnosis. If you get the diagnosis, but few things are not fitting into the parameters, probably they might be a case of subacute or a remote hit. Why is this necessary? Because you need to plan for long-term anticoagulation if at all the patient is a known case of HITT. Okay, so this is the reason where you need to classify and categorize the patient into one of these parameters to prevent further occurrence of thrombosis in these patients. Okay, so you have a patient with HIT, you have a suspicion, you do the 40 score, a lower score, probably any other cause have to be ruled out. If you have an intermediate or a high score, do the functional, first do the immunoassay and then do the functional assay. Based on that, you can get the diagnosis of HIT. So this is in just about the workup for the diagnosis of heparin-induced thrombocytopenia and thrombosis. So who are the patients who usually needs all of this workup? So we were talking a lot of these patients. So what usually happens? What is given to them? What set of patients are they? So this is what we need to understand, and this is you beautifully, represented in this particular cartoon here. Okay. So what we need to see here is there are two groups of patients that you can see. One, patients who have been exposed to either low molecular weight heparin or unfractionated heparin. Fondaparinux, as you can see, does not usually have any issues. Okay, so this you can try and omit. Only thing you need to know which kind of patient, what is the risk involved. So if you see green here, the probability of hit is usually low. Okay, what you need to look at is the red and the yellow boxes. Okay, if the patient is an obstetric case and the use of unfractionated heparin, probably they fall into an intermediate risk. But if they have undergone a major surgery or any type of surgical intervention, the with the use of unfractionated heparin, the possibility of hit increases. So that is what you need to understand by this uh, pattern. Am I clear till here? Okay. So coming to the management, first and foremost, whenever you have a suspicion for the possibility of hit, stop heparin. Okay. So heparin is the inciting adverse drug, which is causing the adverse drug reaction, right? So stop that. And then categorize your patient based on whatever labs have come back to you, right? So into a possibility of acute hit or a subacute hit or a remote hit. Okay. So usually whenever this happens, you need to know what type of presentation the patients are in. Okay. If the patient has been diagnosed with HIT with the occurrence of thrombosis, that is HITT, then there is role for anticoagulation for 3 to 6 months. But if the patient just has an isolated hit without the occurrence of thrombosis, anticoagulation until platelet recovery is usually what is beneficial for such patients. Usually the platelet recovery is what they look at, usually a platelet count of more than 1.5 lakhs. Okay. So unless you get this, you probably have to put them on an anticoagulation, and then you can withdraw the anticoagulation based on whatever indication it was started for, just not for it. If the indication for anticoagulation for some other reason was there, please continue the anticoagulation. Okay. If it was only isolated head, probably the patient came for some surgery, and because of surgery and heparin exposure, the patient developed this. Then, if the patient has developed a mild hit, then you can think of with stopping anticoagulation after the patient has received or reached a platelet count of more than 1.5 lakhs. So, what are the anticoagulation therapies that you will consider if a patient has been diagnosed with HIT? Okay, so usually there are four things you need to remember. Always remember one thing in HIT. Okay, if this question comes, it's always revolving around the number four. Okay, it's the 40 score. It's the four parameters. Usually, most of the things are around the number four. Okay, so remember these things clearly. So again, when we talk about anticoagulation is based on clinical stability. If there is, limp or life-threatening ischemia, which is occurrence because of thrombosis, is there a possibility of whether there is renal dysfunction or a liver dysfunction which is present for such patient? This is also something that you need to see. Okay, based on this, you can either choose oral, IV, or subcutaneous anticoagulant. The details of which I'll be sharing in the further slides. Okay. All that you need to remember is whenever the patient's clinical stability and all is not good, right? So you see the red dots there. Oral is usually taken into picture only when the clinical stability has been achieved. Okay. So unless you reach a clinical stability, the use of oral drugs is not advocated. What I mean to say is you cannot start the patient either on warfarin or any of the oral 10A inhibitors, factor 10A inhibitors, okay, unless you get the clinical stability. Usually, what is advised is the use of IV anticoagulation, usually argatroban or bivalirudin, okay. So we know that usually the oral anticoagulation, whichever you use, are based on two mechanisms of action. Either they are direct thrombin inhibitors or factor 10A inhibitors. I've already discussed about fondaparinux. The other drugs which are there for the factor 10A inhibitor is danaperoid. Okay, the most commonly which is available in most of the centers, especially the vascular centers, which usually have a higher burden of the occurrence of HIT, uses fondaparinux. Okay. So very rarely they use argatroban or bivalirudin. Only thing that we need to remember is argatroban is usually used in patients with a probable renal disease. So that is because the metabolism is usually hepatic for argatroban. So bivalirudin on the other side is usually plasma proteases. So if at all the patient has a liver disease, um, you can usually think about this because metabolism per se is usually renal. Okay. So coming to oral anticoagulation, when can you start? Okay, acute hit, don't start any oral 10A inhibitors. Okay, especially if the patient is by chance already on warfarin for some other issue and it has not been checked, please stop that. If the patient is taking warfarin, the risk of these patients developing a thrombus at that particular time, despite them being considered to be anticoagulated, will be higher. Okay, so please stop them and start them usually with an IV drug. Okay, probably you can start in something called as a lead-in dose of an apixaban. So what they call what is usually used is apixaban of 10 mg twice daily, or rivaroxaban even 15 mg twice daily can be used in such patients. What you need to remember is these patients have an initial decline in protein C factors. Okay, this is usually why you start with heparin and then start vitamin K also, which is one of the reasons. Okay, so what usually happens is patient would be still in a prothrombotic phase. So the patient should be bridged over to vitamin K antagonist after starting factor 10A inhibitors. Okay, similar. Similarly, you have done all of this, but the patient is still not improving. So the next question all of us would be thinking is, it's an immune-mediated adverse drug reaction. Is there a role of IVIG or plasmapheresis? So the evidence still now is not very strong. There have been multiple case reports and case series which have given indication there is benefit for IVIG in acute phases, which is associated with increased bleeding. Okay, so what usually is the mechanism of action of IVIG is usually it saturates the platelet of FC2 receptors, and because of which there cannot be any a placement of the complex of platelet factor 4 and heparin sitting on the platelet FC segment, and then the activation leading to release of granules, etc., and the cascading phenomenon will be offset. So that is the working principle of IVIG. Usually it is reserved for severe and refractory hit cases, or else in patients who requires immediate or urgent surgical intervention, probably in cases of cardiac transplant or a vascular surgery for a relook surgery. Okay, in such cases, probably you can give IVIG if the patient is having an intermediate to high risk or a severe refractory hit, and then patient can be taken up for the particular procedure. Okay. So one more important thing is FDA approval is still not there, and it gives a black box warning for the potential risk of thrombosis with the use of IVIG. Okay, so this is something that we need to consider. So there is another entity called as autoimmune hit. Okay, so autoimmune hit is actually a spectrum of disorders. Okay, what you need to understand is it does not fit into the major criterias for the classical hit, that is the 4T score. Okay, what usually happens here is there is a super antibody which causes the anionic molecule to be present. which activates the platelet factor 4 immunoglobulin complex, and that causes the trigger effect onto the platelets, leading to a immune-like reaction. Okay, so there are 6 types of autoimmune hit. Okay, it can range with hit along with DIC, especially when the platelet count is less than 20,000. Delayed onset hit, usually after 30 days, like a long standing hit, can be a probability of autoimmune hit. If the hit is persistent after 1 week of heparin cessation, even that falls under the probability of autoimmune hit. Hit which occurs without any previous exposure to heparin is also a type of autoimmune hit. We have already seen fondaparinux has not been associated with it. Probably if there is any IgA or IgM type of an antibody causing hit, that can be fondaparinux associated autoimmune hit. Okay, and usually flush related heparin, which is actually quite less. Okay, so if that causes hit, that is usually categorized as autoimmune or a minor type of a hit. Okay, the basic workup and treatment does not change much. Okay, here it is similar to that of the classical hit. You check for thrombosis, look at the thrombocytopenia, do an immunoassay and a functional assay. Only thing is stop heparin use and use a non-heparin anticoagulation based on the severity of the illness which the patient is having. Especially if the patient is having a lot of bleeding manifestation, probably you can still use IVIG as seen in the classical cases. The whole goal of management of HIT is decreasing the use of unfractionated heparin wherever it is possible. Use unfractionated heparin or alternatives. Okay, interventions whenever it is planned. Probably we can look at the reduced exposure of unfractionated heparin. Proper monitoring of these things are necessary. Categorization, early diagnosis and treatment, especially to prevent a long-term morbidity associated with heparin, is something that we need to look at, especially because this is associated with loss of limb and loss of life and increased mortality and increased hospital length of stay. If the patient has come in for a daycare procedure or something like that, and the patient has an exposure to heparin for some other reason and then stays in the hospital, so these are all the issues that can happen because of it. Okay, these are the overall goals that can be associated with the management of heparin-induced thrombocytopenia. Coming to differential diagnosis, what we need to know is sepsis-induced DIC, drug-induced thrombocytopenia, HUS TTP, which we are going to discuss in the further class. Probably sequestration due to splenomegaly and transfusion reactions. Okay, these are the differential diagnosis of heparin-induced thrombocytopenia. So this is the diagnostic algorithm I've already mentioned. Use the 40 score, check the probability, whether it is intermediate or high. Get the enzyme immunoassay first and then the functional assay. Enzyme immunoassay, look at the optical density. Okay, based on that itself, you can get a probability. In the meanwhile, stop heparin here itself. Okay, whenever you have the 40 score getting an intermediate or high possibility, discontinue, start the patient on non-heparin anticoagulation. That is very important, and I'm stressing it time and again. Then you can go ahead with the obtaining the definitive diagnosis, because the further algorithm doesn't matter at all, because here the further testing only goes on to be done to get the accurate diagnosis. The treatment per se would be to stop heparin and to give any alternate anticoagulation. So that is what I need you to take home today. Okay. So in summary, it's an immune drug reaction. Use the 40 score, sequential testing, use of non-heparin anticoagulation with stoppage of heparin as early as suspicion, leading to more than a score of 4 in 40 score. So this is the reference. Thank you. Any questions you guys have? Okay. Just look at the chat box. Sorry, there's some. Okay. Okay. Shall we go to the next topic? Okay. Is my screen visible?
Yes,
Okay.
sir.
Thank you. So we have already discussed about a particular thing called as heparin-induced thrombocytopenia and thrombosis, right? So we're coming to the next thing in hematology, that is the point of care testing in coagulopathies, that is the viscoelastic assays. This topic more or less would be a bedside or a practical thing question more likely than something which they ask routinely in your theory exams. But if at all they ask, probably it can be asked as a sub question in one of the major questions. So per se, asking for viscoelastic or a point of care testing in coagulopathies might not usually occur. Okay, but working principle, okay, and probably differential diagnosis, etc., based on use of TEG or ROTEM can be asked in your exam. So the outline of the next topic would be under the headings of basics. What is the need for a viscoelastic testing? What is the methodology and working principle of viscoelastic testing or point of care testing like TEG and ROTEM? We'll solve a few examples and we'll summarize. Okay. So we all know basically coagulation. This might be one of the questions they can ask you. Okay. So explain briefly about the clotting mechanism and then talk about the use of viscoelastic testing. So that might be one of the questions. So we all know time and again from MBBS days that usually the coagulation pathway or the cascade is divided into an extrinsic system and then intrinsic system, and there is a common pathway, correct? And what we all see here is they are intertwined here, right? And this extrinsic system, usually the trigger is by a tissue factor of factor 7, which converts into an activated factor 7 and then activates the factor 10. Similarly, in the intrinsic system, the factor 12A is what usually gets triggered, and that also more or less goes and activates factor 10 with all the other coagulation factors which are involved in between. The whole point of the formation of clot and the strength would usually be the activation of factor 10A to conversion of prothrombin to thrombin, which acts on the fibrinogen to form a fibrin, which forms the clot stability. So this is usually in total about, or in broad about the coagulation cascade. So what usually the testing we do in routine basis to assess coagulation would be usually for the extrinsic system, we use the prothrombin time or the PT. For the intrinsic system, we usually use APTT. Thrombin time is routinely not done. Okay. So what we otherwise usually do is the INR, which gives us the international normalized ratio based on the prothrombin time. That is the PT. Usually 3 to 6 seconds is what is okay. Anything more than that, if usually 17 seconds and above, probably there is an issue with the extrinsic system of the prothrombin time. Okay. So this is what is one of the things that you need to know. But having said this, does the coagulation system usually go in this? Is there any other way that you guys know that, we describe the coagulation cascade? Is there any other method to describe coagulation cascade?
Amplification, propagation.
Excellent, excellent, Dinesh. So usually the other way of representing this, if you see the ISTH guidelines or the American Society of Hematology, they usually advocate the usage of this following cascade mechanism. That is the initiation, amplification, propagation, and stabilization. Okay. So I told you here, right? It doesn't matter if it is extrinsic or intrinsic. It does depend on the activation of factor 10A. That is what usually happens here. Okay. So in the initiation phase, the whole thing is about activation of factor 10A, which causes the activation of prothrombin to thrombin. This usually is triggered by the expression of tissue factor. This usually happens in the endothelial cells. Okay. So based on this, what happens is there will be an active amplification phase wherein all the other procoagulants or the factors, coagulation factors get involved. Okay. And based on that, from prothrombin, thrombin would be converted, and thrombin acts on fibrinogen in the propagation phase, wherein the activity of fibrinogen comes in. Okay. And the final stage of stabilization is wherein you have a strong clot, that is fibrin, which is intertwined. Okay. The strong scaffolding would be placed. So this is the newer way of explaining the coagulation cascade. Okay. So it is initiation, amplification, propagation, and stabilization. So whatever usually I was talking to you about is whenever we think about a coagulation abnormality, we send in a coag profile, right? So coagulation profile, usually whatever we do in routinely consists of PT, APTT, INR, platelets, and fibrinogen. Usually the sample required would be around 2 points, roughly around 3 ml to 5 ml, right? Depends on what they're, doing. And whatever usually we do, there are a lot of drawbacks with this. What are the drawbacks? They were usually designed for looking at monitoring the therapeutic anticoagulation and not to check for coagulation abnormalities. Okay, so this is the first drawback, and usually does not account for any cellular clotting components. Okay, and most of the times what happens is there is longer turnover time. Okay, usually involved with these things. Okay, so most of the times you guys know, right? If you send in your coagulation profile, probably you can get the whole test. Turnaround time roughly will be around 2 to 3 hours in most of the laboratories. Okay, at the best. If you're getting the 3 hours, probably the possibility of if at all the patient is in an active hemorrhage would be quite bad because you don't know what to do. You'll be doing everything and probably you'll not be achieving hemostasis. Correct. So these are the drawbacks. You should remember they were not intended for therapeutic anticoagulation. I mean, they were usually used for monitoring therapeutic anticoagulation and never for the diagnosis of coagulopathy. They usually don't account for any cellular clotting components. They usually have a longer turnaround time. Okay, these are the drawback for the routine coagulation testing. So we all know that hemostatic aberrations can usually be chronic or acute, correct? So whenever that happens, if it is a chronic issue with bleeding manifestations, it can be due to liver impairment, issues with hematopoiesis, issues with chronic kidney disease, or hereditary hemostatic disorders. If it's an acute event, it is usually associated with trauma or acute blood loss due to surgery or obstetric hemorrhage, or it can be due to sepsis causing consumptive coagulopathy or a transfusion reaction or the use of drugs, etc. Correct? These are the possibilities of any issues associated with coagulation. So whenever we have these, we have a lot of medicines available to us, correct? So it can range for any type of blood products, be it platelets or platelet concentrates or use of a whole blood. A lot of things. Right now, whole blood is not available. I'm sorry for the use of PRBCs, etc. Probably we'll be not addressing to the main cause, but rather we would be just trying to stop the bleeding without understanding the appropriate cause of bleeding. So that is when we need to understand the point of care devices which are necessary at that particular time to prevent unnecessary use of all these medicines, which by themselves can also be detrimental to the patient. Okay. Another thing is whenever we are using this, we do not know how much to use, how long to use, when to use, and what to use. Correct. So usually these questions always remain with us whenever we see a patient with active bleeding. So these things can be sorted out if we use a point of care testing with of coagulation, that is the viscoelastic testing. Okay. So they are viscoelastic tests are actually global tests which are performed on whole blood. Okay. The first viscoelastic test was a thromboelastograph. Okay, it was first done in 1948 in Germany by Helmut Hartart. Okay, so it helps us understand both the qualitative and quantitative measurement of the coagulation system. Okay, it also includes a lot of other finer details like the problem with fibrinogen, platelets, initiation of formation of clot, and even about clot lysis, which usually is missed by the other coagulation testing, which we routinely do. Okay. So what I mean to say is hyperfibrinolysis is usually omitted whenever we are thinking about coagulation profile assessment. Okay. So the use of viscoelastic testing is majorly to see these three parameters in a clot. Okay. So it usually is assessing the formation of the clot. It assesses the strength or the firmness of the clot, and it also assesses the breakdown. So this is the advantage of viscoelastic assays as compared to the standard testing methods for coagulation, which usually does not look into few of the parameters like firmness or strength and breakdown. Most of the times what they look at is formation. Okay. At the maximum, yeah, probably the strength of the clot can also be assessed. So what we usually do is usually take in whole blood and do a continuous rotational force assay, which is usually the one, the working principle for any viscoelastic testing. If the continuous rotational force is combined with an electromechanical transduction, then the test is called as ROTEM, or rotational thromboelastogram. Okay. If it uses the continuous rotational force uses optical detection, then it is called a thromboelastogram. Okay. Are you guys with me? Any doubts still here? Okay. So the major difference between a TEG and a ROTEM, if you see the label A, you can see that whenever we take a sample of blood right here, there is a transducer, there's a processing unit, there is a pin and a torsion wire, correct? And you can see the rotational arrow placed here. So in a TEG, the moving element is the cup, okay? Whereas the pin and the torsion wire is stationary, which is usually connected to the electromechanical transducer to get the data processed. In a ROTEM, on the other hand, what usually happens is this cup is usually stationary, but the pin goes into a to and fro rotational movement. Okay. So this to and fro rotational movement is picked up by an optical device. Okay. What usually happens is there will be an incident ray, which is usually picked up by the receiver, and that received data is sent for processing. So what you need to remember is, excuse me, in a ROTEM, the pin is the rotating element, whereas in a TEG, the cup is the rotating element. So which is better, ROTEM or TEG? Have you, how many guys use viscoelastic testing routinely? Do you guys use it?
Yes, sir.
Okay, what do you guys usually use? TEG or ROTEM?
Egg.
TEG. Okay, okay, okay. So TEG is fairly, something which is more simple to use. Okay, but ROTEM needs to have basic understanding, and if you have to go in a stepwise fashion to understand. Okay, TEG or ROTEM both are good. Okay, so any transplant units you usually have them. We usually use ROTEM. Okay, so TEG usually has one drawback. The cup is the rotating element here, right? And the pin is stationary. So what happens is the shear forces during the rotation of the cup can cause problems in accurate measurement of clot formation. Okay, so this is what you need to understand. So in that way, ROTEM becomes a little more stronger test for assessment of initiation of formation of stabilization and firmness. Okay. It's usually a theoretical thing. Okay. It does not mean that TEG is inferior to ROTEM or something like that. But yeah, the only thing is you need to remember is the mechanical shock, which is usually present in TEG, is absent in ROTEM. Okay. Am I clear?
Sir, can you show the previous slide?
This one?
Yes, sir. Optical detection is ROTEM or
Oh, sorry. Yeah, it's in ROTEM.
okay.
Yeah.
Okay, sir.
Sorry. It's my mistake. So both of this, no, actually it comes under the same graphical representation. So whenever you have a viscoelastic test being done, the image which is obtained is this. Okay. So you have two major things that I want you to look into this. Okay. You have an initial thrombogenic phase, and then you have a fibrinolytic phase. Okay. Here. So the various details of the individual, parameters I'll be discussing in the next slide. Okay. So what I usually want you to understand is the other testing did not have fibrinolytic parameters. It usually checks the thrombogenicity. Okay. So what is the advantage of TEG and ROTEM and viscoelastic testing is the presence of the fibrinolytic assessment, which is adding as an add-on feature for TEG and ROTEM. Okay. So we all have to know that there is a pin and a sample of blood which is present. The other advantage is the amount of blood required for testing here would be very minimal, 0.1 ml or 0.2 ml, depends on the test which we are doing. Okay, they would usually specify the amount of blood. So that is fairly fractionally less as compared to routinely what we send for analysis. So that is another difference or advantage of viscoelastic testing as compared to the routine laboratory testing. Okay, so basically there is a clot formation. Okay, so initially it starts here, and then there is an amplification of all the parameters, and then you'll have the sorry stabilization of the clot. Okay, so this is what you need to understand. It is similar to how we talk about the clotting cascade. Okay, so coming to the individual definitions of the variables involved in the TEG or ROTEM. So we all saw, is this quite visible to you guys? Is it clear, the image? I hope it's not too crowded. So what I want you guys to look into these is, there are parameters. If whatever you see here in the green, right, it is for the TEG parameters, and purple, it is for the ROTEM parameters. So we'll start with the thrombogenic parameters. So the thrombogenic parameters are reaction time, kinetics time, and the alpha angle in the TEG. Similarly, the CT or the clotting time, the clot formation time, and the same alpha angle in the ROTEM. Okay, so these three things usually form the thrombogenic part of the TEG and the ROTEM. Okay, so usually the reaction time or the clotting time is time until the clot amplitude of 2 millimeters is reached. Okay, so this is what is the R time or the clotting time. Okay, in TEG or in ROTEM respectively. Coming to kinetic time, it is the time until the clot reaches an amplitude of 20 mm from the 2 mm initial amplitude. So R time is time till 2 mm is reached. From this K time or the kinetic time or the clot formation time is between 2 and 20 mm. Okay, so between this is the K time. So if you draw a tangent at this particular position wherein the clot formation increases from 2 mm to 20 mm, the tangent to the horizontal of the initial arc at the CT, that angle is called the alpha angle. Am I clear? It is the angle between the central horizontal line and the tangent to the curve through which the 20 mm amplitude point is reached. Am I clear about it? So this is the alpha angle. Okay. So usually these three parameters or variables are the ones which help us understand about the thrombogenesis or the clot formation. Okay. The next two parameters, that is the maximum amplitude and the or the maximum clot firmness, as it is called in ROTEM parameters, and the lysis parameters or maximal lysis, as it is called in ROTEM. Okay, so usually what happens in TEG is they usually check it at 30 minutes and 60 minutes. Okay, so usually that helps us understand hyperfibrinol lysis. Okay, so hyperfibrinol lysis is usually a condition associated most commonly in trauma. So in such cases, the use of tranexamic acid is necessary. So that parameter is something that is usually checked by these two parameters, that is the MCF and the lysis 30. Okay. Are you guys clear, or you want me to repeat anything? Thank you. Okay. So coming to the recall, in the classical pathway, whenever you have to check, you just have the CPC, PTINR, fibrinogen, and D-dimer to basically assess the enzymatic pathway, the platelet, and the fibrinolysis, right? Whereas in TEG, you usually use these things. So I told you about the R time or the reaction time, correct? So R time is the first part in the graph here, correct? So whenever you're talking about that, usually it takes into picture all the enzymatic pathways here. So this any aberration in the coagulation parameters or factor deficiencies, you see there is an increased R time. Okay. So coming to the K time and the alpha angle, usually it's between the activation of fibrinogen to fibrin and the clot per se being formed with some amount of stability. So if that is involved, usually you see an increase in K or the alpha angle. Okay. So coming to the amplitude and the lysis 30, usually the amplitude is associated with both the amount of platelet which is present along with the fibrin polymer. Along with that, if you have an issue with lysis parameters, is usually because of plasminogen and plasmin activity. Okay, the plasmin activity, if it is altered, because of which there will be alteration in the lysis pathway. Okay, so this is what you need to understand. R time, if any changes are there, it is usually associated with factors. K and alpha angle is with the fibrin or the fibrinogen in TEG. Amplitude, platelets, lysis, usually with plasminogen converting to plasmin. Okay, so that is the hyperfibrinolysis. So remember, like this, you have an injury. Okay, just imagine that one of the phlebotomists comes to your patient's bedside, has taken a blood sample. Patient is known to be coagulopathic. Correct. There will be a vessel injury. There will, usually, if nothing is wrong, the patient will go into the following pathway. They'll have a vessel injury. There'll be activation of the clotting mechanisms. There will be a formation of an immature clot, which usually consists of platelets and the coagulation parameters. And then the fibrin comes in because of the activation and conversion of fibrinogen to fibrin, and there will be an immature clot cutting converted to a mature clot. And once there is factor 13 being present and there is a stability and proper scaffolding present, the strength of the clot is achieved. That is the maximum amplitude. So once this happens, the other part of the clot has to be broken down, right? Only the bridge here has to be present, and further activation of the clot should not be present. So the trigger should be broken off here. So that is usually associated with fibrinolysis. So the rate of clot breakdown is what is usually tested, and that is associated with lysis 30. Okay. Initiation is the R time. K time is the fibrin getting initiated and the initial clot forming. And the maximum amplitude is where you have all the parameters and platelets being present. And then after the clot is achieved and hemostasis is achieved here, the extra clot which was there has to be broken down, and that triggers a process called as fibrinolysis, and that is checked by lysis 30. Okay, so remember this table very clearly. So any aberration in the R time or the K time or the alpha angle, you need to look at the possible problems. If it's R time, probably there is issue with the things I've told you. That is the coagulation parameters. Probably the patient needs an FFP at that time. If it is with the K time and the alpha angle, both being prolonged, probably the patient has a deficiency of fibrinogen, and that is one of the things that we need to look into it. Okay. If you have issues with maximum amplitude, then the problem is with the deficiency of either fibrinogen, or it can also be by platelet count. Okay. At this particular time, you have to look into the platelet count. If there is thrombocytopenia and probably fibrinogen being fairly normal, first correct thrombocytopenia. Despite correction of thrombocytopenia, the bleeding is present, then you might have to correct the fibrinogen. Okay, so that will be the step of approach for alterations in maximum amplitude. If there is fibrinolysis which is present, if it is early or if it is too early, that can be hypercoagulable state. If it is lower, it is usually hypocoagulable. So whenever it is hypocoagulable, at that particular time, we need to administer tranexamic acid. Okay. So is it clear? Anything else you guys want to know here? Okay. So TEG as a guide, all that you need to remember: increase R time, give FFPs; increase alpha angle, give cryo. Okay, because that is usually associated with decreased fibrinogen. If it is maximum amplitude, start with platelets. If it is fibrinolysis, which is the issue, then give tranexamic acid. Okay. So most of the times what usually happens is, despite you guys doing all of this, still if the bleeding is not controlled, then you might have to consider the use of Mindrin or DDAVP. Okay. Coming to the next talk, that is ROTEM. So we have already covered TEG. ROTEM is another type of viscoelastic testing. So what usually happens is sample is usually placed in a cuvette and the cylindrical pin is immersed. The gap between the pin and the cuvette in this is usually 1 mm, okay? And the whole gap is usually covered by the blood. It is similar to what happens in TEG as well, okay? So the whole thing is the pin is rotating here as compared to the cup rotating in the TEG. And this alternating movement of the pin from the right to left with an angle between 4 and 45 degrees helps us understand the formation of the clot and its propagation. Okay. Whenever there is a clot which is being formed, what happens is there will be a restriction of movement of the pin, which usually is picked up by the optical sensor, and that gives us the graph. Okay. So this is what usually happens in ROTEM. Okay. So there is a cup which has a blood, and then there is the pin which is rotated, and then I've already told you there is optical detection for which we see the movement of the pin, and when the clot forms, the movement gets restricted because there is some amount of resistance which comes in, and that usually is represented graphically. Okay, so similar to what you see in TEG, same type of a graph is also seen in ROTEM. Okay. Only thing is there is change in nomenclature of few things. Okay. R time gets converted to CT, K time gets converted to CFT. Alpha angle remains as alpha angle. That's the only advantage that you guys can remember if at all you need to. Okay. Rest of the other thing is amplitude at 10 minutes, lysis after 30 is two other, amplitude after 10 minutes is something which is added on in a ROTEM, which is usually not present in TEG. Okay. MCF usually represents the maximum amplitude in TEG. Okay. And lysis parameters are usually an indication of fibrinolysis. So clotting time, initiation of clotting, thrombin formation and clot polymerization. CFT, fibrin polymerization, stabilization of a clot with presence of thrombocytes of platelets, and the activation or the use of factor 13. Okay. And maximum clot firmness is increasing stabilization of the clot by the polymerized fibrin associated with the presence of thrombocytes as well as factor 13. So only thing here you need to remember is the stabilization factor which comes in MCF. Okay, the maximum lysis as similar to lysis 30 in TEG. You usually see for the fibrinolytic pathway. Usually, if it is less than 15% or more than 15% at the end of 1 hour. Okay, the basic ROTEM graph similar to TEG has a two-dimensional thing. Okay, usually the x-axis is time in seconds and the y-axis is the amplitude in millimeters. What you need to understand is the greater the amplitude is the firmer the clot is. Okay, so what you see here is when you start the green, there is a green line here, there's a pink line here, and there's the blue, right? So usually the first one is the CT, the pink line is the CFT and the alpha angle, and the blue usually corresponds to the rest of the thing, that is the MCF. Okay. So this is something that I've already mentioned about. Okay. So whenever we get this, use this graph as one of your reference tools. Okay. If you have some problem with the CT, that is the clotting time, like in TEG, you have problems associated with the intrinsic pathway. Probably you have some factor deficiency. Look at the PT, APTT if you already have them. Okay. Or else I'll be discussing how to interpret XTEM, INTEM. Okay. So if there is association or problem with the mean maximum clot firmness, that usually is attributed to low fibrinogen or platelets. Always go with platelets and then the fibrinogen. Okay. And if there is an issue with the fibrinolysis, that is usually associated with lysis 30 or maximum lysis. Okay. So, what is the advantage of doing a TEG or a ROTEM as compared to a routine test, which we usually do is previously when TEG was introduced, they had to ask for a freshly drawn sample of blood. Usually, it used to be present at the bedside, okay, and most commonly used in transplant patients. So they could easily take the sample, like how we do an ACT in patients who are undergoing angios and bypass, etc. Right? So similar to that is what even TEG was being used. Okay, so there should not be use of any citrate or calcium, which usually acts as an activator. Okay, so that was found to be time consuming. Again, whatever initially we mentioned about the drawback of the routine tests, the classical tests, the turnaround time turned out to be around 1 hour. Okay, so these things are usually offset in the use of ROTEM. Okay, the thing which ROTEM uses is the citrated blood. It doesn't require a freshly drawn blood. Okay. So you need to understand there are various parameters or variables, like how we spoke about K time, R time, etc., along with those things where we have the CT, CFT, alpha angle, MCF, and the lysis 30, there are things, graphical representations that we need to know. Okay, the first graphical representation is the XTEM. Okay, in XTEM, the coagulation is usually activated by a small amount of tissue factor. Okay, so the first step in ROTEM is to do an XTEM and look at what does the graph look like in an XTEM. Okay, this usually leads to the occurrence of a formation of clot within 70 seconds. Okay, so the whole clot formation can be assessed within 10 minutes if you do this properly. That is, you see the XTEM is started here. Okay, at the end of 10th minute, you fairly have an idea where the clot is going to progress, right? So this is what helps us understand better. So that is one of the reasons why XTEM becomes the first step in the assessment of ROTEM. Okay, so you need to remember that tissue factor is what is used for the activation of clot for such blood. Okay, you use a citrated blood. For that, you add tissue factor and look at how the clot forms. Okay, in INTEM, on the other hand, the clotting is activated by contact phase, okay, which is similar to what they do in APTT and even ACTs. Okay, it's similar to that itself. So in INTEM, what happens? Intrinsic factor deficiencies is what is looked at. Okay, and sometimes INTEM is also used for the presence of heparin and the effect of heparin on clotting parameters. Okay, so usually what happens is there's already a clot which is formed, and the CFT time is what is usually taken into picture. Okay, so that is the use of INTEM. So XTEM uses tissue factor. INTEM uses contact phase, which is similar to APTT and ACT. On the other hand, for simple understandings, if you have to know, similar to extrinsic pathway, that is how the name came in. Okay, extrinsic pathway checks tissue factor, so XTEM. Intrinsic pathway checks APTT, so INTEM. Okay, so that is the basic nomenclature and understanding of XTEM and INTEM and ROTEM. Okay, so the other thing is FIBTEM. Okay, so FIBTEM is actually an activated XTEM itself. So basically, for every patient, you have to do an INTEM and an XTEM. Okay, once you do INTEM and XTEM, the next step what you do is a FIBTEM. So here, the activation is you use a tissue factor and check the XTEM parameters. After that, you use something called as cytokalasin D. So by the use of cytokalasin D, the thrombocytes are blocked. Okay, and then you see whatever graph comes in, and that should represent the fibrin polymerization. Okay, so what it does it is FIBTEM, as the name suggests, it looks at only fibrin polymerization and fibrin formation. So it minuses out all the other effects. So by this you can understand. So then the next question would arise: how will we know this is sufficient, whether it is correct or not, right? So this is something that usually you have to check XTEM, INTEM, and then FIBTEM. And there are certain reference values which are given, which I'll be sharing later. Okay, so based on those reference values, you can tell that it is normal or not. Okay, so just remember this graph clearly. Okay, so there is no other parameters that you see except one pink bar there, right? So that is because the effect of all the other factors have been removed in FIBTEM. In APTEM, what it usually does is it also activates XTEM by the addition of aprotenin or tranexamic acid. Okay, so usually checks the fibrinolytic pathway. So what we usually do is we first run the XTEM and used APTEM as the comparator between the XTEM. Okay, so usually this is used for checking rapid detection of fibrinolytic pathways. Okay, if I put the graph, you'll be able to understand. So what you usually do is first you run the XTEM and then you get a certain graph like this. Okay, and then to this you use tranexamic acid and see what happens. By the use of tranexamic acid, what you can see is the MCF actually improves and the clot breakdown or the lysis is prevented, correct? So this helps us understand that the problem in this pathway or the clotting issue in this part, a patient would be hyperfibrinolysis, which is offset by the use of tranexamic acid. Are you guys with me till here? So I will anyways be going in detail again, okay? So that you, and I'll summarize it time and again. So the next part of it is heptem. So we have spoken about XTEM, INTEM, FibTem, and Aptem. Okay. Along with this, we are talking about Heptem. Okay. So what we talk about Heptem is it is the effect of heparin, okay, on the clotting mechanism or the coagulation pathway. So in Heptem, what usually happens is we have to run an intem as compared to Aptem and Fiptem, where you use extem and then you compare it with extem, right? So here in heparin, whenever we use heparin, it is an anticoagulation. You can remember it that way, okay? So you compare the effect of addition of heparinase to the intem parameters. So you see here, there is a prolonged CFT, right? So there is a prolonged CFT probably because there is some factor deficiencies, and that is because of the use of heparin. At that particular time, what you do, you put a heparinase into that patient and see what happens. So there is rapid correction of the CFT, that is normalization of CFT on addition of heparinase. So when there is normalization of CFT on the addition of heparinase, that means to say that heptem is positive. So at that time, you can understand that heparin is the culprit here that is causing the prolongation of CFT. Okay. Am I clear till here? Okay. So in just extem, remember it is extrinsic pathway activity, intem intrinsic pathway, fiptem just measures fibrinogen, aptem looks for hyperfibrinolysis, and heptem assesses for the activity of heparin. Okay. So these are the usual ROTEM reference values that you need to remember. So I told you earlier, when you talk about FibTem, right, nothing else matters here apart from fibrin, right? So this is usually what you need to understand here. See, there is no normal values for CT, CFT, or any other things like lysis 30 or maximum length. The only thing they talk about is the angle, maximum alpha angle, and the maximum clot firmness. Okay, so this is what usually is assessed for a FibTem. So this, based on this, we can tell whether it is in the normal range or not, because you will get a value in this particular range for FibTem. Okay, so how do we approach a ROTEM report? So you get a ROTEM report. So how do you go about? So if you have understood all these pathways, so first thing you need to assess is clot firmness is normal or reduced. So you look into the graph as soon as it comes to you. You look at the extem and you look at the intem. You look at the CT, CFT. You look at the maximum amplitude. You look at the basic morphology of the graph first. Okay. And then if you feel both of them are okay, then you look at the FibTem. Okay. If the FibTem is normal, then probably it is okay. If it is reduced or the thickness has come down, probably it's an issue related to fibrinogen. In the next step, you need to look at the other thing. Okay, what happens if there is prolongation of the CT, CFT, or the change in the angle? What might be the problem, whether it is coagulation activation or any other issues? So you need to look at the possibility of hyperfibrinolysis or the use of heparin. Okay, so these two things are something that you usually have to occur in step 3 and step 4. Okay. So this is how you go about. Start with extem and intem, look for fibtem. Then either you can do an aptem or you can do a heptem. Okay. So based on whatever is the underlying etiology. Usually you can omit one of these things if you know the underlying thing. If you feel the patient is a cardiovascular patient on a bypass, no, you can probably avoid the use of heptem. You can directly do a heptem and see what is the effect of heparin, if it is residual effect of heparin is still present despite your ACT showing a normal value. Okay. So usually extem, you remember these factors are involved, factors 7, 10, 5, 2, 1, and platelets, and probably you can also use it for fibrinolysis. If you're using intem, the factors are 12, 11, 9, 8, 10, 5, 2, and 1 in that order because it also comes in the common pathway. Okay. So in FibTem, as I've already told you, it usually uses the addition of cytokeratin D, which blocks the platelets. Okay. So when it blocks the platelet, the only thing which is visible is the fibrin component of the clot. Okay. So based on the fibrin component of the clot, you can either look at the alpha angle or the MCF value and then decide whether the issue is with the amount of fibrinogen that is less and that is causing the bleed. Okay. In step 3, use the aptem. Okay, by use of aptem, you can rule out whether there is presence of hyperfibrinolysis. Okay, whatever aptem does is first it checks the heptem. So there is lysis 30 is actually earlier, right? So the clot is breaking down quite early. So that means to say there is hyperfibrinolysis. So because of which, if you add tranexamic acid, if the clot strength prevents and the lysis is prevented, and the clot normalization happens, that is attributed to hyperfibrinolysis. So addition of tranexamic acid, because of which there is correction of hyperfibrinolysis. The test done as aptem. Heptem, the role of heparinase. So if at all there is a prolongation of CFT and you see this present, the change present after you adding heparinase, if there is a rapid correction of the CFT, that is probably associated due to the use of heparin. Okay, that is the step 4. So look at these 3 things first: intem, extem, fiptem, fibrinogen activity, aprotein pathway, or tranexamic acid. Okay. So anytime you see a tapering like this, always remember that is usually associated with early lysis. If you see a clot like this, that is the normal graph. Okay. If you see the usual thing here between the 2 lines, the amplitude is lesser, probably the clot is forming. Probably the problem is with the reduced amount of platelets, or probably if the platelets have also been corrected, probably the issue is with the fibrinogen. Okay. So these are few of the examples that you can see. Okay. So first you use an intem and the corrected heptem. Okay. So we have an intem showing a prolonged CFT. Heparin effect is what was suggested. That is the reason the CT was 350 seconds. Once this was corrected, the clotting time came down to 210 seconds. So this usually suggests a heparin effect. Okay. So look at these graphs. Okay. There are a few examples that I have in the end. So you guys have to answer. Okay. I'm actually putting these images and data so that you guys look into this. Okay. Please look into it. So here, when you have intem heptem, it is what you need to see is probably the effect of heparin on the clot forming time. Okay. CFT. And you're using extem and fiptem, you're looking at a pathology associated with fibrinogen. Okay. And the A10 is around alpha angle is around 4 mm, or the A10 is around 4 mm. The issue is with the fibrinogen. So at this particular time, if you see something like this, probably might have to give fibrinogen to this patient. Okay. So, and another thing that you need to see is, if at all the same thing happens, if fiptem is normal, even the A10, you're not reaching an adequate amplitude. The other possibility I've already mentioned, if it is not the fibrinogen, it is the platelets. So at that particular time, the thing that is necessary to be given is platelet transfusions. So early tapering, early lysis. So this is what you need to know. So what we usually do is an aptem test. So compare extem to aptem. If aptem shows normalization of extem, that is associated with hyperfibrinolysis. So give tranexamic acid to these patients, and they will recover quickly, and you can get a stable clot formation. So what is this? Can anyone go about explaining? Okay. No one wants to answer this? Okay. This is a normal ROTEM graph. No, you see there is a normal CT, CFT, extem you see, intem you see, that is normal. You see the amplitude normal, fiptem is normal, aptem is also normal. So this is a normal ROTEM. Okay. So can anyone say what is the problem here? It's very classical, please. Guys, you can attempt this. Come on, guys. I think it's very clear. Okay. You see the intem and see the heptem. The answer is there itself. See, whenever you have, see, the graph actually comes like this. Okay. Heptem. Yeah, good. Go ahead.
Factor deficiency there.
Factor deficiency. Yes. What is the major issue here? You are seeing a heptem being normalized. That's good. Factor deficiency is the answer.
Effect of heparin.
Very good. Okay. So this is one of the common questions they even ask in, your EDIC and all. Okay. They give a thing like this and they'll ask you interpret the data. So please learn your ROTEM. The only reason that we are spending a lot of time on viscoelastic thing is if not in your DRNB, DM exams, you might be asked questions in your EDIC. Okay. Most of you might be giving that. So this is the reason we are spending more time. Okay. So this is absolutely correct. Like one of you mentioned, this is the effect of heparin. Okay. So whenever you have this, look at the intem and you look at the heptane. If it is correcting, probably, use protamine. If protamine also doesn't correct it, and then probably you can think about giving other factors. Okay. Like FFPs, after FFPs, then you can look at the FIPTEM, which is not mentioned here. If the FIPTEM is small, then you can think about usually giving fibrinogen or a cryo, and then based on the MCF, then you can think of the use of platelets. Okay. So whenever you have this as a station, right? So go in this particular order. Okay. Since FIPTEM is not given here, you can still tell that yeah, I would like to, I mean, this is the case of probably the effect of heparin on the clotting parameters. I would like to correct that. I would like to look into the amount of heparin being used. Can anyone tell how much heparin and protamine antagonizes?
1 mg antagonizes 100.
Good. Awesome. Yeah, so we have to know that. Okay, so you remember all of this. Okay, so if you can answer that clearly, then you will get better points. Okay, I mean marks. This is easy, guys. Please, I've told multiple times. What is it?
Fibrinogen.
Yeah. So fibrinogen. Okay. What's happening here? What is happening to extem? You see the extem. If fibrinogen is there, I would agree, but there is some issue with that. There is issue with fibrinogen, but you see what happens to the angle and this thing there. What is happening to aptem? What is happening to fiptem?
Fibrinolysis.
Yes. Okay. There is issue with fibrin. Correct. That is lysis. Okay. So it is a combined hemostatic disorder. All of this is present. So all of you were correct. Okay. So what we see here is the most outstanding thing is hyperfibrinolysis. Okay. You see what happens to your aptem, intem, both the things. Okay. And the extem. So here, all of this is subpar, right? You're not, see, this two dotted green lines usually gives you an understanding of the normal values, okay? So if it's not reaching any of those and you see intem, there is prolongation, okay? Here also you're seeing this. So you compare extem and aptem for hyperfibrinolysis, hyperfibrinolysis. Use intem to see the effect of clotting parameters. Okay, here probably the heparin was there, heparin was not there, so you can still think about whether there was heparin effect. So because the intem has a prolonged CFT, correct? So that is something that you need to know. In FIPTEM, again, you see it's just a brown green line. Usually pink line is what we expect to come there, right? So what it means to say is even the amount of fibrin which is being present is very minimal. So that is called as the zero line. Okay, there is no clotting at all. So what usually the patient needs is a rapid combined treatment. So these kind of patients usually is a traumatic patient. Probably the patient has come with major trauma, massive transfusion protocol, guided therapy. This is something that you need to understand. Okay, this is a picture you can see in trauma-induced coagulopathy. Okay, so we will be discussing about TIC when we discuss about trauma. Okay, but remember this. Okay, so like you guys said, no, there was clotting factor deficiency. There was issue with fibrin. Okay, but you have to use both of them. Okay, you have to look at extem and aptem. You have to look at intem for a few things, and you have to look at the fiptem. Here, all the graphs were wrong. Okay, so this is what I want you to understand. Okay, am I clear, or guys want me to explain anything? Okay. So with all of this understanding and talk about this, no, there are a lot of guidelines, the European guidelines, the British Society, the European Society, Perioperative American Society of Anesthesia, and even the trauma guidelines. Okay, none of them actually give a level 1 evidence. All are B at the max C. Okay, so all of them do not tell that you need to do viscoelastic testing as the primary tool or investigative method for management of a bleed. They always say that you go with the routine tests and then follow up with the viscoelastic assay. So the problem is widespread availability of these tools and widespread usage of tools. These tools are not present, and there is no single authority which is forming guidelines for the use or algorithmic approach for the management of a bleed using viscoelastic assays. Okay, so robust data is still lacking. Okay, so you can just tell that it has level grade 1B, that is the European guidelines, which is fairly recent in 2019. For goal-directed strategy, it still gives a grade 1B recommendation. Okay, so this is one thing you can remember because it's one of the latest ones. Okay, rest of the things you can tell the robust evidence is still not present. So where is ROTEM or TEG lack? The only thing is to monitor the therapeutic effects of antiplatelet drugs, etc. We cannot use. Okay, even for DOACs, we cannot use them. Okay, so can anyone say what do we do for such things? Is there any tool to know? Okay, actually,
There's no tool.
sorry,
There's no tool, sir.
there is a tool.
Platelet function.
Platelet function.
Monoclots.
Anti-10A assay.
Okay, individual assays are always there. Okay, but the only thing is that whenever you're talking about antiplatelets and this thing, right? So, firstly, yes, when you're talking about antiplatelets, ROTEM itself, the machine, the company comes in, no? They have something called as platelet aggregation assays. Okay, so that is one thing, and individual platelet function assays. So that is one thing you need to know. And yeah, individual factor assays are very costly, and the turnaround time is usually long. By the time you actually get that, the patient might not be alive. So unless your city has a few major cities will have it. Yeah, the smaller tier 2 cities probably it would be difficult. So this is where you have done everything possible and still the patient is bleeding. What would you do? So you have checked platelets, you have given blood, you have given fibrinogen, you have given cryo, you have given factors, everything, even factor 13, I would say. Still, you're having some bleeding issues. What would you do? Before giving factor 13, no, anything else should be checked in. After that only, usually we give factor 13. It's actually in a stepwise fashion, okay? So individual problems, so solve that. That is low platelet to give platelet transfusion, coagulation, FFP, fibrinogen, cryo or FFP. And then later on, you go in for the next specific things. So what is the next specific thing that you do before giving factor 13? DDAVP, okay? Sometimes Mindrin is the trade name which is present, okay? So 0.1 to 0.25 mg per kg is what usually is given, okay? So this is the drug which activates the subendothelial coagulation cascade to prevent fibrinolysis or activation of the clot. And this helps in the stabilization of the clot, okay? So this is something that you guys need to remember. So these are the things that are the therapeutic interventions for individual clotting parameter, which is changed. Okay. The take home message for ROTEM or TEG, look at whatever the issue is, whether the CT is prolonged. If it is CT, give FFP. Similarly, in TEG, the R time would be prolonged. So at these times, you have to use FFP or the concentrates. Okay. If that is normalized, then look at the MCF value in ROTEM and the maximum amplitude in TEG. So based on that, either you give platelets or if the fibrinogen is the issue, you give a cryoprecipitate. Okay. In ROTEM, what you usually check is the FIPTEM. Okay. So if the FIPTEM is low, give cryo. If the FIPTEM is normal, then give platelets. Okay. So then you look at the clot lysis. Okay. And if there is lysis which is quite earlier, then you have to give tranexamic acid. Similarly, use lysis 30 and lysis 60 in TEG. Okay. So whatever it is, it's the initiation, propagation, the same thing. Okay. It's the first slide whenever we talk about it. Okay. So that is what you need to remember. Thank you. Anything else you want to ask? Is there anything you want me to repeat? I'll be happy to share anything if you guys want. Okay, there are a lot of articles which are present. Okay, don't break your heads. Just remember a few things. Probably it will be a practical thing. go through these slides in an order so that you will be able to, understand and answer. Otherwise, most of the review articles that I went through, it is present, but it is not in an orderly fashion. So this I found out to be more helpful when I read it. So that's how I put it across. Okay. So if there's anything, please message in the group or leave in the chat box. Probably I'll be able to answer them. Okay. Thank you. I think so. I'll be handing over to Niharika ma'am next. Ma'am, are you there?
Yeah. Hi, Darshan.
Hi, ma'am.
Thank you, Darshan. It was a very good class, viscoelastic testing.
Thank you, ma'am.
Especially the ROTEM. So as Darshan mentioned, ROTEM for DRNB theory, practical, yeah, it is important, but more important if you're planning to give EDIC. So in EDIC, they won't be asking anything about TEG. It is the ROTEM which they usually ask. So if you're planning to give EDIC, please go through these slides once again, okay? And please solve a lot of problems on the same. Then only you will be able to understand. Otherwise, just reading the theory, just remembering the normal, I think, values will not be so much helpful. So as Darshan showed a lot of examples, please go through the other examples. Then you'll be able to solve it and remember it easily. Okay, Darshan. Thank you, Darshan. So today I'll be discussing about two other important topics. One is the tumor lysis syndrome, and the next one would be the therapeutic plasma exchange. So first we'll go through the tumor lysis syndrome. Able to see my slides?
Yeah, I think so. You open it up, ma'am. Still.
Okay. Just one sec. I think now it's visible, right?
Yeah, yes, ma'am.
Okay. Okay. So I think you people have seen a lot of cases on tumor lysis syndrome. You have treated a lot of patients with tumor lysis syndrome. So just if any additional points, you can just go through that. So I'll be discussing about the introduction, the definition and classification, the pathogenesis of the tumor lysis syndrome, what are the risk factors, and management, which covers both the prophylaxis as well as the treatment. Now, coming to the previous year question, it was been recently asked in DRNB 2022 as tumor lysis syndrome 5 marks. And previously, it's been asked multiple times in the FNB exams too. So what is TLS? So tumor lysis syndrome is an oncological emergency with high morbidity and mortality, especially if the diagnosis is delayed and the treatment measures are not instituted promptly. So the most important aspect here is to rapidly identify the patients at risk for TLS. So this can occur either spontaneously or after any anti-neoplastic therapy. So it could be the conventional chemotherapy, or if you're giving high-dose steroids, or any molecular targeted therapies, immunotherapies, and even after a radiotherapy and chemoembolization, because all involves the lysis of the tumor cells. Now coming to the definition and the classification. So this definition was actually given by Hande and Guerrero in 1993, and they have similarly classified as the present one, the laboratory and clinical tumor lysis syndrome. But the thing is, they never knew that there was a spontaneous tumor lysis syndrome which was present, and this has been discovered, or it has been modified by the Carrier and Bishop in 2004. So basically the definition includes the two things. One is the laboratory TLS and the clinical TLS. So what does the laboratory tumor lysis syndrome tell? There should be any modification of at least 2 parameters within the 24 hours. So what are the laboratory, testing which is important is the uric acid, potassium, phosphates, and calcium levels. So if the uric acid level is more than or equal to 8 mg per dl, if the potassium value is more than or equal to 6 mg per dl, and the phosphate more than or equal to 4.5 mg per dl, or if there is the evidence of hypocalcemia that is less than or equal to 7 mg per dl, then any two within 24 hours, if there is any change in these, then it is a laboratory TLS. Okay, or you can also tell that 25% increase in uric acid, potassium, or phosphate, or 25% decrease in the calcium levels. Okay, this is about the laboratory TLS. Coming to the clinical TLS. So clinical TLS includes the laboratory TLS plus the organ, any one organ dysfunction or death. So what could be the organ dysfunctions? It could be any renal dysfunction or involvement of the cardiac system like arrhythmias, any neurological involvement like seizures or tetany, or if there is a death happening. Okay. So this should occur either spontaneously or within 3 to 7 days after the initiation of the chemotherapy drug. Okay. So this is the definition, the modified Carrier and Bishop scoring or the definition. Now coming to the pathogenesis. So what happens in tumor lysis syndrome? So when the tumor cells get lysed, there is a release of certain substances. So in that, the most important one is the phosphate, the release of nucleic acids, and some inflammatory mediators. So when there is a release of phosphate, it binds to calcium in the blood, leading to the formation of calcium phosphate crystals. Okay. And when there is a release of nucleic acid, especially the purines, okay, they lead to increased formation of uric acid, which may form a crystal and lead to uric acid crystals. Both the calcium phosphate and the uric acid crystals, they precipitate in the renal tubules, leading to the AKI. Okay, this increased uric acid can also be available as a soluble form, along with the inflammatory mediators, may lead to non-crystal dependent mechanisms. Okay, like they may lead to vasoconstriction, release of oxygen free radical, and inflammatory mediators leading to acute kidney injury. So this is the pathogenesis of the tumor lysis syndrome causing acute kidney injury. So as I told, so the purines, okay, when the adenosine monophosphate and the guanosine monophosphate, so adenosine monophosphate is further metabolized to hypoxanthine, and guanosine monophosphate is reduced to xanthine. So when this hypoxanthine is converted to xanthine with the help of something known as xanthine oxidase enzyme. Okay, so this xanthine oxidase enzyme also convert the xanthine to the uric acid. Okay, and this uric acid is the one which is the main important component for the pathogenesis in the TLS. So we have different drugs which are used for the treatment of this TLS, especially two important drugs, the allopurinol and the rasburicase. So the mechanisms, I will explain it in detail, but just because we are just going through this flow chart. So allopurinol basically inhibits the xanthine oxidase. So it helps in prevention of formation of xanthine as well as the uric acid. Whereas rasburicase basically converts this uric acid, which is insoluble, into a soluble form that is nothing but the allantoin, which is excreted in the urine. Okay. So coming to the pathophysiology. So as I told, hyperkalemia. So this tumor cell lysis leads to the release of large amounts of potassium into the circulation. The capacity of which is so much that the muscle and the liver can't metabolize it. Hence, it is excreted into the urine. So it is even more pronounced in the setting of CKD or any pre-existing AKI. And as we know, hyperkalemia leads to muscle fatigue, muscle paralysis, arrhythmias, and even death. Coming to the hyperphosphatemia and hypocalcemia. So these malignant cells have 4 times higher levels of phosphate than the normal cells. So when the tumor lysis happens, you get a huge amount of release of phosphate, leading to hyperphosphatemia. So this high levels of serum phosphate can lead to the precipitation of calcium phosphate in the renal tubules, leading to nephrocalcinosis, especially in patients with an alkaline urine. Okay, these calcium phosphate, they also precipitate in the conduction system of the heart, leading to conduction abnormalities as well as fatal arrhythmias. So when this phosphate combines with the calcium, okay, there is less amount of calcium in the serum, so it leads to hypocalcemia, which may be symptomatic or asymptomatic. So when it becomes symptomatic, we know the lot of what are the signs and symptoms like neuromuscular excitability, like tetany, there could be seizures, arrhythmias, and even death. Okay, so this hypocalcemia may persist even after the resolution of hyperphosphatemia, possibly due to the vitamin D deficiency, especially if the patient has vitamin D deficiency, and Indians already have a vitamin D deficiency. So this hypokalemia could be persistent even after the treatment of hyperphosphatemia. So there is some value, okay, that is the calcium into phosphate value, okay. So when this value is higher than 60, there is an increased risk of the calcium phosphate precipitation in renal tubules. And when the product is more than 70, then it is an indication for dialysis. So you can calculate this and tell that whether the patient might require dialysis or not. So this is one of the indicator for the need of dialysis. Now coming to the risk factors. So the risk factors can be divided into the tumor risk factors and the patient-related risk factors. Coming to the tumor risk factors. What are the types of tumors which might have an increased risk factor? Okay, for which, so it could be either the solid tumors or a hematological tumors like acute leukemias and the non-Hodgkin's lymphoma. Coming to the solid tumors, you have the germ cell tumors, you have the neuro and medulloblastomas, the small cell carcinoma of the lung, any breast, ovarian or vulvar neoplasms, hepatoblastoma or hepatocellular carcinomas, colorectal carcinoma and gastric carcinomas, melanomas and sarcomas. These are the highest risk of precipitating the TLS. Now, next coming to the tumor volume. Okay, if the tumor size is more than 10 centimeter, there is an increased risk of tumor lysis syndrome or any metastatic disease. If the tumor growth rate is very fast, how do you measure that? By measuring the LDH. If the LDH is more than 2 times the normal value, then the growth of the tumor is very fast. Coming to the level of leukocytosis, if it is more than 25,000, and how sensitive is the tumor for the chemotherapy? More sensitive to the, more chemosensitive, then more risk of TLS. Okay. Then coming to the patient-related risk factors, like males are more prone for TLS, older people like age more than 65 years, pre-treatment serum creatinine means they are, the baseline AKI, or if they are diabetic nephropathy or anything, the creatinine is more than 1.4, then they are risk for TLS. Any renal obstruction, if the pre-treatment uric acid levels are more than 7.5, and any associated conditions like hypotension, hypovolemia, use of any nephrotoxic drugs, or if the patient has an underlying CKD. Now coming to the management. So in TLS, rather than the actual treatment, the most important thing is the prophylaxis. How to prevent TLS. That is most important rather than actual treatment. Okay, so management should focus on identifying patients who are at risk to develop the TLS and on prompt prophylaxis. So the key of prophylaxis is basically to maintain an adequate urine output and to decrease the blood levels of uric acid, potassium and phosphate. Okay, so how do you monitor? When to monitor all these values? Okay, so the monitoring of biological values are recommended to be done with the following frequency. What are those? If the patient has a high risk, means greater than 5% of developing TLS, then you have to monitor every 4 to 6 hourly after the initiation of the anti-tumor therapy. If the patient has an intermediate risk, then you can monitor every 8 to 12 hourly. And if has a low risk of developing the TLS, then you can measure it once a day. Okay. Now, in addition, it is recommended to avoid the nephrotoxic drugs, especially the NSAIDs and the contrast agent, and to stop the treatment with ACE inhibitors and the ARBs because they also lead to hyperkalemia. Now, coming to the first important thing, the volume expansion. So it can be accomplished by crystalloid solutions. Basically, why do you want to do volume expansion? It is basically two reasons. One is it increases the urinary output and thus your phosphate, potassium and uric acid will get excreted. So first of all, to reduce the levels of these three, and secondly, to decrease the urinary calcium and phosphate product so that it prevents the precipitation of the crystals. Okay, now what should be the dose of volume expansion that has to be given? So children, we don't need to take. So in adults, you should give at least 3 liters of fluid per day, either by mouth or intravenously 2 to 3 days before chemotherapy. So you're planning the chemotherapy in 2 to 3 days. So tell the patient to take a lot of IV fluids. If they are not able to take, at least give the intravenous IV fluids. Minimum, it should be 3 liters. Okay. And you should monitor the urine output. Okay, so around 2.5 liters per day of urine output should be present. Next, coming to the diuretics. Is there a role of diuretics? No. Routinely, it is not recommended because it may cause volume depletion and may compromise the renal hemodynamics. Only if there is a symptomatic hypervolemia, then you can give the dose of diuretics. And what type of diuretics is preferred? It is the loop diuretics. Why? Because they increase the urinary flow plus they increase the potassium secretion also. But do not use thiazides because they increases the blood levels of uric acid. So the best one, if you want to use the diuretic in case of symptomatic hypervolemia, is the loop diuretics, the furosemide. Now coming to the urinary alkalization. So initially, I think this urinary alkalization was included in the treatment of the TLS, but now it is not recommended. Why? We will see now. So basically, theoretically, what does it do? So it favors the conversion of the uric acid to urate. Okay, and decreases the tubular crystal precipitation. Okay, so this is one of the advantage. I mean, theoretically, this is the advantage, but what is the disadvantage of alkalinizing the urine is that it decreases the calcium phosphate solubility and it favors crystal precipitation in renal tubules and soft tissues. It decreases uric acid crystals, but it precipitates the calcium phosphate crystals in the renal tubules and soft tissues. Also, it increases the amount of calcium that is bound to albumin and it favors arrhythmias and tetany. Basically, it leads to hypocalcemia. Okay, so that is a reason now urine alkalinization is not recommended as a treatment in TLS. In fact, it is very dangerous. Now coming to the calcium supplementation. So routinely calcium need not be supplied only if the patient is having symptomatic hypocalcemia, then you need to give calcium. Because if you give calcium, okay, thinking, yeah, patient has a hypocalcemia, he is not symptomatic. So this calcium is actually used to form the calcium phosphate crystals. Okay, because this, whatever calcium you're providing, the phosphate is going to bind to that and form a calcium phosphate crystals. And actually it aggravates the formation of these crystals and leads to AKI. So only it is recommended in severe and symptomatic hypocalcemia and if there are any changes of ECG and arrhythmias. Okay. So in these cases, treatment is administered in order to alleviate the symptoms and not to normalize the calcium. So don't think of normalizing the calcium. Now coming to hyperkalemia, I think hyperkalemia, you know, how to treat, what are the values of ECG changes. I think everything has been discussed. So it must be promptly treated because it can induce life-threatening arrhythmias. So whenever there is more than 25% increase or the absolute values reaches more than 6, then you have to start the treatment like use beta-2 adrenergic agonists, glucose insulin, calcium gluconate, potassium binding resins, everything. So if the value is more than 7, then dialysis is recommended. Special attention is needed for the drugs that may increase the potassium serum value. So be careful if you're using these drugs in the TLS patients, please stop it. Okay, especially if you're using any digoxin, verapamil, mannitol, NSAIDs, ACE inhibitors, calciurin inhibitors. So please stop all those drugs which cause increase in potassium levels. Now coming to the allopurinol. So allopurinol is nothing but a purine analog and is the isomer of the hypoxanthine. So it is metabolized by the xanthine oxidase to oxypurinol. If you see here, okay. So this is the allopurinol. It is metabolized by the xanthine oxidase to oxypurinol, which is nothing but the active form. This is the one which actually helps in the prevention of conversion of xanthine to uric acid. Okay. So it is metabolized by the xanthine oxidase to allopurinol, which is nothing but the active form of allopurinol, which is nothing but a competitive inhibitor of xanthine oxidase. So this allopurinol decreases the production of uric acid from xanthine. But you should remember one thing, it has no effect on the already synthesized uric acid. Okay. So it only prevents the new formation of uric acid, but not on the already formed uric acid. This leads to a weak response to treatment in patients with TLS and severe hyperuricemia. So the serum concentration of hypoxanthine and xanthine increases after allopurinol. Okay, because allopurinol will, basically if you see that this one, it, okay. So xanthine oxidase acts here as well as here. So when allopurinol is given, so the concentration of xanthine as well as hypoxanthine both increases, and these both also have the tendency of forming the crystals. Okay, so that is one of the disadvantage of giving allopurinol in these patients. So the serum concentration of hypoxanthine and xanthine increases after allopurinol, and xanthine can precipitate into the renal tubules leading to AKI. Therefore, it is recommended to use allopurinol as a prophylactic treatment and not in case of an established TLS, because one is the thing, it forms crystals. Second, it only prevents the formation of the new uric acid, but not on the already formed uric acid. Okay, so it is only used for prophylaxis, but not in the established TLS. It can only be used in established TLS if the patient has any contraindications to rasburicase, like if the patient is allergic or if the patient has G6PD deficiency, then as a treatment, you can use allopurinol. Otherwise, it's only used for prophylaxis. Now coming to the doses. So adults, it is given as 200 to 400 mg per meter square per day, divided in 1 to 3 doses. Maximum is 800 mg per day. And it has the dose should be adjusted in case of renal impairment according to the EGFR. So if you're planning to give the allopurinol as prophylaxis, you need to start the treatment 24 hours prior to the chemotherapy initiation, and you need to continue it for the next 7 days after initiation of the chemotherapy. Okay. And the other disadvantages is that it has multiple drug interactions, especially with 6-mercaptopurine and azathioprine, where you need to reduce the dose of allopurinol by 65 to 75%. Also, it has a lot of drug interactions with thiazide, cyclophosphamide, cyclosporin, ampicillin, and amoxicillin. Side effects are rare, but if anything it occurs, it is life-threatening. Especially it causes Stevens-Johnson syndrome and TENS, acute toxic hepatitis, small vessel vasculitis, bone marrow aplasia, and even DRESS. So that is about allopurinol. Coming to the next, febuxostat. I think we don't use much of febuxostat in TLS, but it is a new inhibitor of xanthine oxidase. And the advantage is that it does not induce the hypersensitivity reactions which is seen with allopurinol, and it doesn't necessitate any dose adjustment if the patient has any renal impairment. Okay, there was a trial which has been performed, the fluorescence trial, which tested the efficiency of febuxostat compared to allopurinol in patients with blood malignancies as well as medium to high risk patients of developing TLS. And it showed that febuxostat in a dose of 120 mg per day was more efficient in preventing the TLS. Also, there is a recent meta-analysis which also showed that when compared to allopurinol, it has a better response or an equal response with that of allopurinol. So you can also use febuxostat in TLS. Now coming to the rasburicase. As we know, it is a recombinant variant of urate oxidase, which is derived from the Aspergillus flavus. So it is approved by the FDA for pediatric patients with hematological malignancies who are undergoing chemotherapy in 2002 and for adults in 2009. So it can be used as a prevention as well as for the treatment of already full-blown TLS. So basically what does rasburicase do? As I told, it converts the uric acid into allantoin, the carbon dioxide and the hydrogen peroxide. So we tell that rasburicase, before giving rasburicase, we need to test the patients for G6PD deficiency. Why it is so? So as I told, rasburicase is actually metabolized to allantoin, carbon dioxide and hydrogen peroxide. So this accumulation of hydrogen peroxide in patients with G6PD deficiency may lead to methemoglobin accumulation, leading to hemolytic anemia. Hence, prior starting to the rasburicase administration, we need to test the patients for G6PD deficiency. So it is basically the metabolite of the rasburicase which might lead to the methemoglobinemia in patients with G6PD deficiency. Now, what is the dose? Suppose testing was not possible in your hospital, you can't test for G6PD deficiency, then you can start with a low dose of 0.05 mg per kg. But according to the British Committee of Standards in Hematology, the recommended dose for prophylaxis in high-risk patient is a single dose of 3 mg. Okay. And for children, it is 0.2 mg per kg. And this can be repeated daily for 5 to 7 days when necessary. So how do you see the requirement of RAS uricases? You see the levels of uric acid. And if there is a lack of response or if there is an increase in uric acid levels despite a single dose of RAS uricase, you can repeat it daily, but maximum it can be given to 5 to 7 days. Now, it is very well tolerated with only a few side effects and has less drug interactions compared to allopurinol. And the advantage is that it has a rapid effect. Basically, it lowers the uric acid levels within 4 hours. Okay. Rarely, what could be the side effects it can have? It could induce a rash, fever, headache, nausea, vomiting, or hepatic cytolysis. And it is contraindicated in pregnancy, lactating women, and patients with G6PD deficiency. And one more disadvantage is that, so it continues to be active even ex vivo. So thus leading to false decreased values of uric acid if the blood sample is not immediately delivered to the laboratory. So you have given a RAS uricase levels and you want to test the levels of uric acid. Okay. So you withdraw the blood, put it in the ice, and immediately it has to be processed. Otherwise, this RAS uricase even acts as we mentioned, ex vivo. So it will actually cause to false decreased values of uric acid. Okay, so this is one of the things that we have to do immediately. The blood sample has to be processed immediately. Now coming to the future perspectives in the prophylaxis. So you can prevent through any chemotherapy modulation, like choosing less aggressive chemotherapy regimes so that in order to slowly reduce the tumor burden and allowing enough time for the compensatory kidney mechanisms to improve the products which are derived from the tumor lysis. And secondly, there are other options of enzyme replacement therapy. So why is this option? Because due to the limited efficiency of xanthine oxidase inhibitors and side effects of intravenous RAS uricase, they have actually tried some new enzyme replacement therapies. So as we all know, kidney is the major site of elimination for uric acid, but also some amount of uric acid is being metabolized even in gut, around 30 to 40%. Okay, so they have developed some new enzyme which actually targets this intestinal degradation of urate, that is the Alin 346. So studies have shown that there is a significant reduction of hyperuricemia by around 44% and normalization of uricosuriA. And the other one is the pegloticase. So what is this? This is actually a drug which is used for a refractory gout. Okay, it is a third line treatment for refractory gout. So they have tried even this drug also, and I mean, trials are still ongoing with this drug. They have compared this drug with the RAS uricase, so still the results are awaited, and this drug is also contraindicated in patients with G6PD deficiency. Now that was about the prophylaxis. And if the patient has an established TLS, then how do you treat this patient? So basically, it necessitates a multidisciplinary approach and careful monitoring. So you have to maintain the urine output, IV hydration. And as we know, urine alkalinization is not recommended. And don't use allopurinol for the treatment of TLS. Use RAS uricase in the dose of 0.2 mg per kg per day. And the treatment duration must be established according to the clinical response, the uric acid levels, but not more than 3 to 7 days. And if the hyperkalemia or uric acid is still increasing, then RRT is the last measure which is available for the treatment of TLS. Now coming to the conclusions. So TLS is a constellation of metabolic disorders that occur as a result of malignant cell lysis, which is related either to the treatment or to the increased rate of cell proliferation. So it is an onconephrology emergency, with AKI being one of the most important predictors of short as well as long-term mortality. So according to TLS risk stratification, an early, aggressive and multidisciplinary approach is mandatory in order to limit the occurrence of this condition and consequently the occurrence of AKI. Thank you. Any doubts here? So prophylaxis is totally different. Treatment is totally different. So just see what are they asking in your exams. Okay. So are you people able to see my slides? Guys, are you able to see the slides?
Yes, ma'am.
Okay. So next topic is about the therapeutic plasma exchange. So therapeutic plasma exchange, I think you people are doing it for two important indications. One is the TTP and one is the GBS. Okay, so we will go in detail about the indications. What can be the different principles which can be used here, and how to write a prescription for the therapeutic plasma exchange. So I'll be discussing about the introduction, the different techniques, the basic principles, and writing the prescription of PLEX, indications, contraindications, and the complications. So recently in 2022, they've asked about plasmapheresis, and in 2023 DRNB, they've asked about the indications and contraindications of PLEX. So before going into the actual PLEX, we should know some terminologies related to the PLEX. So three important terminologies: what is apheresis, plasmapheresis, and therapeutic plasma exchange. So apheresis is nothing but a general technique of extracorporeal removal of blood constituents. This is usually done in pathology lab, basically in blood bank, to separate RBCs, plasma, okay, and platelets. So that is the apheresis technique. Now, what is plasmapheresis? So only removal of plasma from a patient is a plasmapheresis. But what is therapeutic plasma exchange or PLEX? It is nothing but removing plasma from a patient, that is plasmapheresis, plus you are giving a replacement fluid. Okay, that is the PLEX. Okay, so many times they have asked in the practical exams between the difference between plasmapheresis and plasma exchange. So if you give a replacement fluid for the plasmapheresis, it is nothing but the plasma exchange. So TPE is an extracorporeal therapy which is performed using either centrifugation technique or membrane filtration. I think most of you people are using the dialysis machine, the membrane filtration technique, but there is also a centrifugation technique which is used in some 4 to 5 institutes only in India. Okay. So what are the ideal characteristics of a substance to be removed by TPE? The molecule should be larger. It should have a larger molecular weight. It should have a good intravascular distribution, and it should have a prolonged half-life. Okay. Now, so coming to the techniques, as I told, there are two techniques, the centrifugation technique and the membrane filtration technique. Now, this membrane filtration can only separate plasma, whereas the centrifugation technique can fractionate any of the blood components, like the RBCs, platelets, and plasma, which is usually done in the blood bank. So both methods, when they compared, are similarly effective at removing the plasma proteins, and each involves administration of a replacement fluid at an equal or a greater volume of what was removed. So if you're removing around 2 liters of plasma, you have to replace around 2 liters of the replacement fluid. So membrane filtration TPE, it extracts a smaller fraction of plasma, only around 30% per unit of time. But when you compare it with the centrifugal system, this will extract around 80%, okay, of the plasma. So the membrane filtration TPE requires a longer treatment times and a higher blood flow rates compared to the centrifugal system. So this can increase the risk for circuit clotting in membrane filtration technique. So coming to the difference between both. So mechanism wise, this uses a centrifugal force, this uses convection. Blood flow, centrifugation requires less amount of blood flow compared to membrane, 10 to 150 ml per minute, and here 150 to 200 ml per minute as we do in the dialysis. Okay, plasma extraction. See here, this around 80% of plasma is extracted, but here only 30%. The other things, the molecular weight, the protein binding, everything is same in all the two methods. But coming to the anticoagulation, for centrifugation, the best one is citrate anticoagulation. For the membrane, it is heparin anticoagulation. So this is the one machine which I was speaking about, the centrifugation technique, the MCS plus machine. So basically here you're going to enter all the characteristics of the patients, how much of volume you have to remove, what is the hematocrit of the patient. So everything will be entered here. Okay, so this is the one where you connect the anticoagulation, and there will be a bag hanged here for the collection of the plasma. Okay, and here a lot of circuits, the circuit will be hanged to all these ports here. Okay, so as I told, centrifugation and membrane. So centrifugation technique, you remove the blood, you give the anticoagulations, especially the citrate. Okay, it goes into the centrifugal machine. Okay, and from one side, the plasma is removed. And when the blood returns to the patient, you give the replacement fluid. The replacement fluid can be either the albumin or the crystalloids or the FFPs. Okay, and then when it returns to the patient, you give calcium. Okay, because I have already discussed about the regional anticoagulation, regional citrate anticoagulation in the CRRT mission. So when you give citrate, you give calcium. Okay, this is the antidote for the citrate. Okay, so usually we give this calcium once in the middle of the the procedure, and once after finishing of the procedure. So coming to the membrane TPE, I think you all know about this. You have the blood pumps, same as the dialysis goes on. So this is the one. So coming to the basic principles and the general considerations. So when to consider TPE? Okay, so basically, this TPE is most commonly used to target a single pathognomic substance. Okay, if you're thinking of TTP, so you want to remove the antibodies against the Adam TS13. Okay. So you want to target a single pathognomic substance from removal from the plasma. And what should be the characteristics of that substance? As I told, it should be a large molecular weight substance, more than 15 Daltons, slow rate of formation. It should have a prolonged half-life, higher percentage of intravascular distribution. This is very, very important. And it should have a low turnover time. Okay. Coming to the vascular access. So, you have to remember that if you're planning for a centrifugation technique, a large bore IV cannula is enough. Okay. But if it is a membrane filtration technique, then you require a dialysis catheter. Okay. So most apheresis devices use centrifugation, and it requires blood flow rates of around 50 to 120 compared with 150 to 200 in membrane filtration technique. Okay. So this TPE procedure can be continuous or it could be discontinuous. If it is continuous, it requires an access and a return catheters. But if it is a discontinuous, okay, you can use a single catheter to serve for the access as well as the return. Okay, so the access depends on number of conditions, like the procedure related factors, like how urgent is the procedure, what volumes to be exchanged, what is the frequency, and patient related factors include what is the underlying disease, what is the mental state of the patient, what is the vascular anatomy, and also depends on the institutional capabilities. So as I told, you can use all this. Okay, but the large bore peripheral IV cannula is best for centrifugal technique, and the central venous catheters are good for your membrane filtration techniques. But if you're using for a long-term purpose, then the subcutaneous ports can be used. And if already a patient is on dialysis for CKD, you can also use the AV fistula for therapeutic plasma exchange also. Now coming to the anticoagulation. Since PLEX is an extracorporeal circuit, there is an extracorporeal circuit, though there is a chance of circuit clotting is more in these patients. So we need to have a anticoagulation to prevent the clotting. So the method of anticoagulation basically depends on the underlying comorbid processes. What is the type of apheresis which we are doing, whether it is centrifugation or the membrane filtration. And if you require the systemic anticoagulation for any other indications, like if the patient is also on ECMO, okay, so what type of anticoagulation to be given, we should decide by taking all these factors into consideration. So two standard anticoagulating agents, one is the citrate and one is the heparin. So coming to the citrate, so citrate, as we know, it has a regional effect, and the advantages is that it has a short half-life and has an excellent safety profile. So it is infused in the circuit before the pump, where it chelates ionized calcium to prevent activation of coagulation cascade. So the mechanism I've already explained in CRRT. So as I told, in centrifugation, the risk of citrate toxicity is low because, as I told, 80% of the plasma will be removed, right? So with that 80% of plasma, the citrate also will be removed. So in these patients in centrifugation technique, the chances of citrate toxicity are less. Hence, the preferred anticoagulation in centrifugation is the citrate. Whereas in plasma filtration, if you use citrate, as I told, only around 20 to 30% of the citrate will be removed because the unit extraction is around of plasma is around 30%. Okay, so in these patients, the toxicity of citrate is much more compared to the centrifugation technique. So best one is for the centrifugation technique, it is the citrate anticoagulation. For membrane filtration technique, which we use regularly, you give heparin. Okay, so as I told, calcium must be replaced orally or IV to avoid the systemic hypocalcemia. And the commonly used citrate solutions are the ACD, that is anticoagulation citrate dextrose formula A and formula B. Now heparin, this is inexpensive, has a shorter half-life and is almost entirely cleared during the TPE. So you give a bolus dose of around 3000 to 5000, and if required, you can start an infusion of 1000 units per hour. And it is a better preferred anticoagulation agent in membrane filtration technique. Now coming to the replacement fluids. So the choice of replacement fluid, it depends on the indication for apheresis as well as the chances of infection as well as the bleeding risks. So you have colloids, you have the crystalloids, or you can do a combination of these two. Okay, so the most commonly used one is the albumin and the FFPs. So albumin, which is commercially available as 5% solutions, it contains approximately 145 millimoles of sodium and less than 2 millimoles of potassium. So this albumin has it has a lot of affinity to antithrombin 3. So when you are giving a albumin replacement, okay, it will result in 50 to 60% reduction in both pro as well as anticoagulant factors. But the thing is, it has the rebound is biphasic, means there will be increase in a biphasic manner. That is, initially after 4 hours of the PLEX, there is an increase in the pro and anticoagulant factors, and almost complete recovery occurs by 48 hours. So coagulation testing should be performed for 8 to 12 hours after albumin replacement is done. If you have any cost issues also, you can actually do albumin versus saline combination. So 80% of albumin and 20% of saline can be used, but there is a lot of risk of hypotension with this technique. Okay, coming to the side effects of this albumin. So it has a lower risk than plasma of causing any hypersensitivity reactions or transfusion related acute lung injury and transmission of infection. So it is better tolerated by the patient. But coming to the FFPs. So the main use of FFPs as a replacement fluid, especially in TTP, is that it contains ADAM-TS13. Okay, that is the reason that you use in TTP FFP as a replacement fluid. Okay, so primarily plasma is primarily used to replenish the ADAM-TS13 in TTP and clotting factors in patients with bleeding, especially the diffuse alveolar hemorrhage. Okay, so but the disadvantages of FFP is that it contains around 7 millimole of citrate per unit. So if you remove around 2 liters of plasma, you have to give around 2 liters of FFPs, means it has a high chances of citrate toxicity. So that is one of the disadvantages of giving a high dose of FFPs. So the thing is, as I told, because 1 unit contains around 200 to 300 ml of FFP, and if you're doing one exchange of 3 liters, you have to replace nearly 10 to 15 units of FFPs. Okay, so this comes with a lot of associated complications also. Okay, so the risk associated with donor plasma include transfusion reactions 1, and the second one is the citrate toxicity. So now this is just, I'm going to ask some 3 questions. Please be active enough to answer this. So I'm reading the question. 50 kg, 42-year-old woman presents with fatigue and headache of 2 weeks duration. In the emergency department, she is ill appearing and with a heart rate of around 115 per minute, and blood pressure is 120/65. She has a petechial rash. The laboratory results has a hematocrit of around 18%, platelet of around 12,000, creatinine levels of 1.3, LDH of around 2,100, and haptoglobulin level of less than 6. A peripheral blood smear shows 15% schistocytes. So the diagnosis would be TTP. Now you decided to initiate the therapeutic plasma exchange for treatment of likely TTP while awaiting the results of ADAM-TS activity. So how would you calculate the estimated plasma volume? So there are 4 options. Can anyone tell me what is the answer for this? I think you have done a lot of, therapeutic, PLEX. So can you just tell me how to calculate, what formula can be used and what is the answer here?
Ma'am, 0.065 into 1 minus hematocrit.
0.065 into what?
1 minus hematocrit.
No, you are missing one thing. So if you calculate like that, what will be the answer? See, any answer is coming? 2.7 liters, 3.7 liters. Just calculate and see, you have already having a 50 kg person here. And the hematocrit is around 18%. So how much you got after calculation? Anyone?
3.7.
3.7. Okay, we'll see later. Now, the second question is, which one of the following is the most appropriate initial prescription? So TTP is diagnosed. So whether you do 2 plasma volume exchanged every other day, alternate day, 2 plasma volumes exchanged daily, 1 plasma volume exchanged every other day, or 1 plasma volume exchanged daily.
Ma'am, 1 plasma volume exchange daily.
Okay, good. Now, which one of the following replacement fluids would be most appropriate? I think already you know the answer. I've already given about the answer, right? It is a frozen plasma. Okay.
Frozen
So how
plasma.
to, yeah, you forgot about this weight ma here. Okay, you told 0.065 into weight into 1 minus hematocrit. Okay, so this is the formula to calculate the estimated plasma volume that has to be removed. Okay, so coming to the average blood volume in adults is around 6.5%, that is around 5 liters, of which around 3 liters is the plasma. Okay, so the estimated plasma volume can be calculated from the estimated blood volume and the hematocrit. Okay, so the formula is this. Please remember this formula. If they ask for what is the prescription, if you get a TTP case, so they're going to ask for the prescription of the PLEX. So just remember this formula, okay? So 1 plasma volume exchange actually removes around 65 to 70% of the targeted substance from the intravascular compartment. So TPE sessions typically exchange 1 volume and virtually never more than 1.5 times the estimated plasma volume. Okay. Now, number of exchanges, what is the duration and when to discontinue? Okay. So if you see a 70 kg adult with a hematocrit of 34 will require approximately, if you put that formula, he might approximately require 3 liters of replacement fluid for a single plasma volume exchange. Okay. As I told, centrifugation, it is a very fast process. So it might take around 1.5 to 2 hours to do this. Whereas in the membrane filtration technique, it is double the time. It might take 3 to 4 hours. Okay. And the frequency and the number of the sessions, they depend on the characteristic of the pathogenic substance. What you want to remove, it depends. So what antibodies you want to remove, any other things you want to remove. So it depends upon the characteristic of that pathogenic substance as well as the time required to reach the desired clinical improvement. So in TTP, what is the end point to see when to stop the PLEX? So it depends on each disease process and what type of the molecule you want to remove. So the following factors are very important determinants of the efficiency of the TPE. Okay, so there are 4 important factors. One is the sieving coefficient. What is this? It is a measure of equilibration of a solute across a semi-permeable membrane. Means outside as well as in intravascular and extravascular, there should be equilibrium. Okay, a sieving coefficient of 1 indicates perfect equilibrium across a membrane and the need for a fewer TPE sessions, whereas a solute with a sieving coefficient of 0 does not cross at all. So if you want to remove also, that will not come out. So you should see the sieving coefficient of the pathologic substance which you want to remove. Second, you should see the plasma half-life of the substance. So substances with a shorter half-life may be synthesized more rapidly. So you will remove within few hours, it gets synthesized. Again, you have to do it very frequently. Basically, you need to do daily to remove that substance. So it depends on the plasma half-life also. Third, what is the concentration of the substance extravascular? Okay, so usually, as I told, the ideal substance should have a intravascular distribution so that it can be removed easily. But if it has a high extravascular proportion of the substance, so first when you remove, the intravascular concentration should decrease. Then the substance from extravascular moves into intravascular, and then you have to remove that substance. So substances which have high extravascular distribution, they will be removed very slowly, and you may need to do it for a longer time. Okay, now coming to the rate of synthesis. Faster synthesis may require more frequent TPE sessions or sometimes additional therapies to decrease the endogenous production. So we have to see all these things and then decide about PLEX. How when we can stop, how many sessions we have to do. So it actually varies with the substance that is present. Okay. So most commonly, especially in TTP, GBS, everywhere, the most common immune complex that is present is the IgG. Very rarely you have the IgM antibodies. So most immune complex diseases are related to the production of IgG, which has around 45% extravascular distribution, which is actually high. Okay. And and it has a half-life of around 22 days. Okay. And it has a low turnover per day. Therefore, several consecutive treatments, each separated by either 24 to 48 hours, will be required to achieve the meaningful clearance. Okay, so either you should do daily or alternate days, and the end point depends on what is the underlying disease. Okay, so in general, TPE performed every other day for 6 treatments will decrease the circulating IgG levels to 16 to 20% of the baseline level. Okay, it is very less. Okay, even if you do 6 treatments, so the decrease of the circulating IgG levels are very, very less. Okay. In contrast, if it is an IgM molecule, okay, it has 80% intravascular distribution. So it can be removed very fast, right? It has a short half-life and a higher daily turnover. So as such, if you want to do TPE, so you have a significant clearance. So immediately it can be cleared. But the thing is, when you discontinue the therapy, it has a faster rebound action compared to the IgG. Okay. So this is the distribution of different plasma proteins. For us, the important is IgG, IgM. This IgA nephropathy and all, I think we rarely see those. So IgG is very important. So intravascular distribution is around 45%, but for IgM, it is 78%. Now, as I told, so how do you prescribe? Now, a patient of TTP has come. So now they tell us to prescribe prescribe some for PLEX for this TTP patient. So how do you prescribe it? So as I told, plasma volume should be either 1 to 1.5 times the estimated plasma volume. So use that formula, calculate the plasma volume and enter it into the system. And frequency, better to do it daily because it is an IgG component which is there in TTP. So replacement fluid, as I told, FFP is the one because it contains the ADAM-TS13 molecule. And duration. So when to continue the session. So as I told, it depends on the underlying condition. For TTP, they tell that until the platelet count is more than 1.5 5 lakhs, and when the LDH levels are near normal for the 2 to 3 consecutive days. Till then, we need to continue the therapeutic plasma exchange. Okay, it does not depend upon the cystiocyte levels. Okay. Now, the next important question which is usually asked in exam is, what are the indications of the therapeutic plasma exchange? So, the American Society of Apheresis have divided these indications into 4 categories, 1 to 4. So, category 1, so apheresis is the first line therapy for these diseases. Now, category 2 is, it is a second line therapy with efficacy favored by available evidence, but conventional therapy should be tried first in these cases. Category 3, the role of apheresis has not been established, so the decision needs to be individualized. And category 4, apheresis is ineffective or harmful in these conditions. So I have only just mentioned about category 1 and category 2 conditions. If you mention this in exams, it is more than enough. So you should know about the category 1 indications. So most common is GB syndrome, acute inflammatory demyelinating polyneuropathy, acute liver failure, anti-GBM disease, that is a Goodpasture syndrome, especially when the patient presents with the diffuse alveolar hemorrhage and patients not receiving the dialysis, catastrophic APLA syndrome, chronic inflammatory demyelinating polyradiculoneuropathy, familial hypercholesterolemia, hereditary hemochromatosis, hyperviscosity and hypergammaglobulinemia, myasthenia gravis, polycythemia vera, TTP, and fulminant Wilson's disease. These are the category 1 indications for PLEX. Okay. Category 2, as I told, this could be a second line treatment in cases of basically refractory diseases. You can try this PLEX here. So examples could include acute disseminated encephalomyelitis. If the steroid refractory, then you can use PLEX. Autoimmune hemolytic anemia, especially when it is cold agglutinin disease. Cryoglobulinemia, graft versus host disease. Okay, hyperleukocytosis, Lambert-Eaton syndrome, multiple sclerosis, mushroom poisoning. Okay. Now coming to the contraindications. So if there is a non-availability of central line access or a large bore peripheral lines, then it is difficult to do the PLEX. If the patient has already an hemodynamic instability or septicemia, you are removing a lot of plasma, so patient might have severe hypovolemia. Any known allergy to FFPs or albumins, or any contraindications to either citrate or heparin. Okay, the relative contraindications are hypocalcemia, and if the patient has taken any ACE inhibitors in the last 24 hours. And lastly, coming to the complications. So just divide the complications into access related, anticoagulation related, procedure related, and replacement fluid related. So access related, I think you people can write hematoma, nerve damage, pneumothorax, everything. Okay, anticoagulation related, if it is heparin, then write about HIT. If it is citrate, then write about citrate toxic intoxication and citrate accumulation. Okay, then coming to the procedure related. So there could be anemia because there is a decrease in the hematocrit. There could be hypotension, there could be thrombocytopenia, any vitamin deficiencies. And coming to the replacement fluid, if you're giving FFPs, then there could be some reactions for that. Albumin, as I told, coagulopathy can happen. So infections, any transfusion related TRALI. Okay, so everything can happen. Okay, so this completes the 2 important topics. I think you understood the prescription for PLEX. If you have any doubts, please put it in the chat box. I will reply to that. Srihari?
Yes, from my takeover.
Okay, yeah.
Is the slide visible?
Yeah, visible, Srihari.
Okay, ma'am. Okay, good evening to all. So Niharika madam had almost covered around 50% of my discussion under madam's topic. So hopefully it'll be less for me to cover. So the thing related to TTP and HAS, and from an exam perspective, the previous questions that they had asked was mainly pertaining to diagnosis and management. But The problem is many of us would not have been exposed to these set of cases. So talking about those topics alone directly would be very difficult because it would be difficult to understand. So what I thought was for these two topics alone, compared to my old PPTs, I thought I'll go little in depth in discussion about the etiology, the pathogenesis also, so that you will get a better clarity about what we are dealing with. So if you have any doubts, please let me know towards the end. I will be happy to answer them. And another thing is, in my PPT, in many slides, there will be some amount of repetition. So I have put it deliberately so that it will be a form of reinforcement, so that you will be able to remember it for a longer period of time, at least till the exams. So going further into the topic, so I'll be covering TTP and HUS. So first we'll go into the overview. So thrombotic microangiopathies are a group of disorders characterized by three things. One is microangiopathic hemolytic anemia, which you can see is characterized by the presence of schistocytes. And along with this, there will be thrombocytopenia, and there will be formation of microthrombi that will lead to ischemic tissue injury. So these three things are supposed to be the characteristic features of TMS. So what is microangiopathic hemolytic anemia, or MAHA? So it's a descriptive term for non-immune hemolysis, that is Coombs negative hemolysis. So it results from intravascular red cell fragmentation that produce schistocytes on the peripheral blood smear. So characteristic lab data that is seen is usually there will be a negative antiglobulin test, that is a direct Coombs test. There will be increase in lactate dehydrogenase levels because of breakdown of RBCs. There will be increase in indirect bilirubin because of increased RBC breakdown and uptake into the liver, the metabolism. And there will be low haptoglobin levels because of increased complex between the hemoglobin and the haptoglobin binding to each other, leading to decrease in the free haptoglobin levels. So TMAs describe a specific pathologic lesion in which abnormalities in the vessel wall of the arterioles and capillaries lead to microvascular thrombosis. Though these conditions are rare, TMAs are life-threatening conditions that require urgent management. So usually if any of these kind of patients are admitted to the ICU, usually most of our consultants would be in a full panic mode because these cases have a high mortality rate, and with the institution of PLEX in the right scenario, the mortality rate comes down very markedly. So that's why if any of these patients are diagnosed immediately, they try to push for plasma exchange as early as possible, so because it has shown to improve overall outcomes. So this is just a renal biopsy where you can see that there are thrombosis that is present, fibrin thrombi that is present within the cellular tissues. So this kind of thrombi which occurs within the tissues interrupts its normal functionality, and that's how it leads to ischemic injury. So there is a wide spectrum of thrombotic microangiopathies. The one you would have been commonly hearing is TTP HUS. So TTP is thrombotic thrombocytopenic purpura, and HUS hemolytic uremic syndrome. So hemolytic uremic syndrome has two subsets. One is typical and atypical. But now the terminologies have changed. Typical is now called as sugar toxin induced HUS, and atypical is called as complement mediated thrombotic microangiopathies. And other etiologies are drug induced and secondary. Now, secondary like infection, malignancy, malignant hypertension, systemic rheumatic diseases, especially in the background of SLE or catastrophic antiphospholipid syndrome, or following hematopoietic stem cell transplant or solid organ transplant. So in all these subset of patients, we always have to have a consideration of TMAs at the back of our mind. But my topic for discussion today will be predominantly on TTP, citotoxin-induced HUS, and complement-mediated TMS. So coming to TTP, I'll be discussing about the introduction, the pathogenesis, clinical features, the diagnosis, and the management. So coming to the introduction, TTP is a form of thrombotic microangiopathy caused by severely reduced activity of von Willebrand factor cleaving protease. Okay, so that is the main terminology that needs to be kept in mind. It is caused by severely reduced activity of von Willebrand factor cleaving protease that is called as ADAMTS13. So it is characterized by small vessel platelet-rich thrombi that causes thrombocytopenia, MAHA, and associated organ damage. That whatever I had explained in the overview. So as I mentioned previously, it is an important diagnosis to make because untreated mortality is 90%, which can be reduced very drastically with prompt delivery of plasma exchange. So it is rare but a potential fatal blood disorder which has an incidence of 2 to 6 per million involving young adults, that is more of females than males. It can be hereditary or acquired. Hereditary can be due to pathogenic variants in the ADAMTS13 gene, and acquired can be because of immune-mediated processes that occur because of autoantibodies that occur against ADAMTS13. So this is the main pathologic pathogenesis in a gist. So these immune-mediated processes can be either drug-induced or autoimmune related. So under drug-induced, it is most commonly associated with immunosuppressives, like most commonly cyclosporin and tacrolimus, antiplatelet agents. HIV per se itself can cause TTP, estrogen-containing contraceptives, and pregnancy. And vasculitic states like autoimmune diseases, most commonly implicated in TTP is SLE. So coming to the pathogenesis, so TTP is caused by a severely deficient activity of the von Willebrand factor cleaving protease, that is ADAMTS13. That is clinically defined as activity level less than 10%. So if the activity level is deficient and the level is less than 10%, then you can very confidently say that the patient is having TTP. So this deficient levels in ADAMTS13, what is it? So the full form of ADAMTS13 is a disintegrin and metalloproteinase with the thrombospondin type 1 motif member 13. Now this will definitely sound like Greek for most of us. That's how it sounded for me. But if you can understand each word from its own perspective, you will definitely have a better clarity. So disintegrin refers to the domain of the protein that interferes with the interaction between the platelets and the endothelial cells. So if you can remember the coagulation cascade, when there is an endothelial, subendothelial exposure, there will be activation of the clotting factors. Then there will be formation of a fibrin clot. Then platelets adhere to it, form a definitive clot. So this disintegrin, which is part of the ADAMTS13, interferes with the interaction between the platelets and that endothelial cells. Next is metalloproteinase. So metalloproteinase is an enzyme which refers to the metal-dependent enzymatic domain of the protein, ADAMTS13, which cleaves the von Willebrand factor. So its catalytic activity is facilitated by the metal zinc. So that is because it has a metal catalytic activity. It is called a metalloproteinase, and its main role is to cut down the von Willebrand factor into smaller structures. Thrombosporin refers to the domain of the protein which is similar to the thrombospodins which have anti-angiogenic properties. So it prevents formation of new vascular cells within the endothelium. And 13 is the 13th member of the ADAMTS family to be described. So there are three important components to be looked into: disintegrin, which prevents interaction, metalloproteinase, which breaks down the 1 Willebrand factor, and thrombosporin, which has anti-angiogenic properties. So this is the easiest way to remember it. So ADAM-TS13 is a plasma protease that was initially defined by its function as a 1 Willebrand factor cleaving protease. So it cleaves the ultra-large string-like molecules of 1 Willebrand factor that are synthesized by the endothelial cells and secreted into the plasma but remain attached to the endothelial surface. This normal cleavage to smaller size multimers prevents ultra-large multimers from accumulating, especially in the areas of high shear stress, like small arterioles and capillaries. So the important thing to note is in these areas, that is the capillaries and small arterioles, when there is unopposed 1 Willebrand factor activity, that is large multimers are present, there will be definitely thrombosis occurring on a large extent. So because of that, RBC flow is going to be affected, oxygen delivery is going to be affected. Ultimately, there is going to be ischemia to the tissues. So that is only going to cause the majority of problems in the subsequent pathogenesis. So this shear stress leads to a conformational change in the large 1 Willebrand multimers that exposes the ADAM-TS cleavage site. So when the protease activity, that is the ADAM-TS activity, is reduced, the ultra-large 1 Willebrand factor multimers accumulate on the endothelial surface where the platelets attach and accumulate. So that leads to platelet aggregation and formation of platelet thrombi on a large scale. So uncontrolled platelet activation and consumption leads to thrombocytopenia, thereby reducing clotting activity, leading to porphyria. On the other side, formation of fibrin stance leads to reduced space for the RBC to pass through, leading to shear stress and injury, leading to microangiopathic hemolytic anemia. So the RBC damage occurs because of these fibrin deposits that occurs, which is intravascular non-immune process. And because of this large amount of platelet thrombi that occurs and it interferes with the delivery of oxygen to the tissues, it's going to cause tissue damage and eventual necrosis. So that can manifest at various organ systems. In the CNS, it can clinically produce confusion, severe headache, and focal neurological deficits. In the heart, it can produce cardiac arrhythmias and sudden cardiac death. And in the kidney, it can produce glomerular damage, leading to decrease in GFR and proteinuria. So coming to the clinical features, so because of this microangiopathic hemolytic anemia occurs, there can be increase in bilirubin levels that can present as jaundice. There can be thrombocytopenia, which can manifest as epistaxis, bruising, petechiae, gingival bleeding, hematuria, menorrhagia, GA bleed, or hemoptysis. Fever, which is usually low grade, that is usually more than 37.5. Renal, there can be AK with proteinuria and hematuria being present. Neurological, it has a wide spectrum of manifestations like headache, confusion, paresis, aphasia, dysarthria, visual disturbances, seizures, and coma. In cardiac, they can manifest as chest discomfort, palpitations, or hypotension. And non-specific features like fatigue, arthralgia, myalgia, and abdominal discomfort may also be there. So the important thing to note is the first 5 features usually contribute to the pentad of TTP, that is MAHA, thrombocytopenia, fever, renal involvement, and neuro involvement. So coming to the diagnosis, we have basic and etiology-based diagnosis. So in basic, in most cases, these are the important tests that need to be done for any cases suspected with TTP. First, you go ahead with a complete blood count to assess for anemia, thrombocytopenia, and a p-smear to assess for cystocytes. You need to do a retic count. Retic count, usually if it is more than 2.5%, it indicates it is high, which may indicate a hemolytic process occurring. Then haptoglobulin levels will be reduced. LDH will be raised because of hemolysis. The direct antiglobulin test or Coombs test is negative. clotting screen will be normal because the coagulation cascade per se is not affected. It is mostly related to the von Willebrand factor and the platelets. Renal function tests are usually they will show an impairment, but it will not be very severe as compared to a HUS patient. And if cardiac involvement is there, usually there will be elevation in troponins, abnormal ECG, and echo findings. Calcium needs to be done, mainly if at all PLEX is being planned, the calcium levels need to be looked into and corrected if it is low, because PLEX itself, one of the main complications related to electrolyte abnormalities is hypercalcemia. Urine analysis also needs to be looked into for presence of proteinuria and hematuria, which may help in aiding in diagnosis. CT and MRI, if at all there are neurological manifestations present. Hepatitis B, C, and HIV to exclude underlying viral etiologies, and for other ICU-related precautions, and coagulation parameters, which is usually normal. Because as I told in the pathophysiology, the coagulation cascade per se is not affected. It is more related to the thrombin-related problems. So coming to the etiological evaluation, the important thing I had put up over here in bold letters is very important to be noted. TTP, HUS, and secondary TMS usually present in a similar fashion. So it is ideal to work up in detail for the pathology, that is the etiological factors. So usually thyroid function test needs to be done to rule out Graves' disease. Autoantibody screening needs to be done to exclude associated autoimmune diseases. Stool culture for pathogenic E. coli if concomitant history of diarrhea is also present. And CT, chest, abdomen, pelvis, plus or minus tumor markers in the appropriate clinical setting to look for underlying malignancy. So the most important test in relation to TTP is the ADAM-TS13 assay. So it includes two things. One is the ADAM-TS13 activity, and the second is the inhibitor levels. In most of the articles that you read, they will be showing flowcharts showing the inhibitor levels. Now, what is this inhibitor levels? It is nothing but the anti-ADAM-TS13 IgG antibody levels. So most large volume setup usually have access to ADAM-TS13 assay, but in Indian setting, in most places, ADAM-TS setting assay is not usually present. So usually they send it to an outsourcing agency or lab where they do it and then they report it to us. So there will definitely be a time delay between the diagnosis and treatment. So what they say now in the current guidelines is not to wait for results before starting treatment in suspected cases. So how do you go about interpretation based on the ADAM-TS13 assays? You have a patient with MAHA and thrombocytopenia of unknown etiology. You've looked in for all possible causes, nothing had fit in. So if you find that the diarrhea, there is a history of diarrhea and the cultures had grown presence of sugar toxin producing E. coli, then your diagnosis is pretty straightforward. It's a sugar toxin related HUS. Otherwise, you check the ADAM-TS13 activity levels. If it is less than 10%, you have to look into two things. One, if there are antibodies present or not. If activity is less than 10% and there are no antibodies, that is inhibitor is negative, then it is a congenital TTP. Whereas if there are antibodies present, then it is an acquired TTP. Whereas if the ADAM-TS13 activity levels are more than 10%, then you need to look in for atypical HUS or complement mediated EMAs. So in those scenarios, you need to look into complement factor abnormalities if it is present or not. If it is present, then it goes in favor of complement mediated TMAs. Whereas if that is negative and there is presence of an underlying condition, like there is presence of a malignancy or a malignant hypertension or an infective background, especially like viral infections, which will produce expanded dengue syndrome, which will produce a marked variation of symptomology and clinical manifestations. They themselves itself can produce a secondary TMS. So that needs to be looked into. In most cases, ADAM-TS13 assay testing may not be available. So in high clinical suspicion, usually you can go ahead with the plasmic score, PLAS MIC score or the French score. So the best way of understanding the correlation between these two is you can compare plasmic score to the sepsis SOFA score and the French score to the Q SOFA score. Because the number of parameters that will be assessed is very less in the French score, whereas in SOFA, there is a little detailed assessment that needs to be done. So this is used to predict the likelihood of severe ADAMTS13 deficiency in a suspected TTP patient. So this is the plasmic score. So the parameters are the platelet count should be less than 30,000. Creatinine should be less than 2. So that is an important thing to note. As I had mentioned, there will be renal manifestations in DTP, but if it is very significantly involved impairment in the renal status, the thought process should go towards other TMAs rather than TTP. So platelets, serum creatinine, presence of hemolysis, where the indirect bilirubin will be more than 2, red tick count more than 2.5 or lower undetected haptoglobin. There has been no active cancer in the previous 1 year, no history of solid organ or hematopoietic stem cell transplant. The INR should be normal, less than 1.5, and the MCV should be less than 90 femtoliters. So all these criteria should be looked into, and if the score is between 6 to 7, then it has a score of probability of 62 to 82%. So this is a very good screening test because the sensitivity is 99%, but it does not serve good as a confirmatory test. For the confirmation, you need to go ahead with the ADAMTS13 assay. So the French score contains just 3 parameters, almost like the Q SOFA, whereby you look into the platelet count if it is less than 30,000, the creatinine if it is less than 2, and there should not be any presence of active cancer or transplant, solid organ or hematopoietic. So score of 1 point is 2%, 2 points is 70%, and 3 points is 94%. So coming to the differential diagnosis, one patient with hemolysis and thrombocytopenia, you can consider autoimmune hemolysis or Evans syndrome. As I had mentioned, TTP is a non-immune hemolysis. So one of the differential should be for an autoimmune. The DAC, especially the best example I can give is usually patients with snake envenomation, when they do develop this kind of picture. So in those scenarios, there have been case reports related to TMAs and there have been case reports related to DAC. So it is very confusing. You need to look into the clinical picture and look into the coagulative profile also to make a diagnosis of DAC. Because in DAC, your fibrinogen levels are also impaired. The PTINR is also impaired. Pregnancy-associated TMAs like HELP syndrome or preeclampsia, drugs like quinine, simvastatin, or calcium urine inhibitors, infections, especially viral, HUS, malignancy, and autoimmune states like SLE, catastrophic Apla syndrome. So coming to the treatment, now there are 4 groups of patients that we can consider in a TTP patient. That is, patients who have a first event, patients who have had a relapse, patients who have an exacerbation, and patients who have a refractory disease. So, having looked into multiple PDFs, I've concised it into these 4 for a quick summary and look through. So, for the first event, the treatment modalities of choice is to go with the therapeutic plasma exchange plus steroids plus rituximab plus or minus caplacizumab. For a relapse, which is defined as clinical plus or minus lab deterioration following remission, that is return of disease more than 30 days after cessation of therapeutic plasma exchange. So that is defined as the relapse, that is more than 30 days. So in that scenario, you go with TP plus, that is therapeutic plasma exchange, plus steroids, plus Ritux, plus caplacizumab. So the difference between first event and relapse is about the addition of caplacizumab. In the first event, in most centers, they do not add caplacizumab, but in relapse cases, comes as the part of the protocol management. So exacerbations is recurrence of thrombocytopenia without another cause following a response, but it occurs within 30 days after stopping therapeutic plasma exchange or caplacizumab if it had been given. And for refractory states, it is a lack of clinical response to initial treatment with lack of alternate diagnosis to explain the findings. I repeat, the refractory disease, it is a lack of clinical response to the initial treatment with the lack of alternate diagnosis to explain the findings. So coming to the treatment, that is the first event. So I am just going to go into the 4 modalities that I had explained. So therapeutic plasma exchange, like Niharika madam I just explained in the previous presentation, it is the mainstay of treatment for TTP. So all patients with a presumptive diagnosis of TTP plus or minus confirmed diagnosis based on ADAM-TS13 assay are treated with therapeutic plasma exchange till the platelet count recovers or an alternate diagnosis is established. It should be started with 1.5 plasma volume using solvent detergent plasma. That is ideal. So now the next question would be, what is a solvent detergent plasma? So compared to the other forms, SD plasma is one that is treated with viral inactivating agents prior to freezing. I repeat, SD plasma is one that is treated with viral inactivating agents prior to freezing. And initially, once it is started at 1.5 plasma volumes, based on the clinical stabilization, it can be reduced to 1 plasma volume. And daily plasma pheresis should be continued for a minimum of 2 days after the platelet counts has improved to more than 150,000, and then only should it be stopped. So that is about the therapeutic plasma exchange. So coming to corticosteroids that are used in conjunction with therapeutic plasma exchange in suspected or confirmed cases of TTP. So it acts by reducing the production of ADAM-TS13 inhibitor, that is autoantibodies. Plus, it helps to decrease the cytokine production, thereby reducing organ damage. And it helps to decrease the autoantibody mediated clearance of ADAM-TS13. So the drug of choice is methylprednisolone, and it is given as pulse of 1 gram IV over 3 days. Then it is gradually tapered over 3 to 5 days, and then switched over to oral prednisolone of 1 milligram per kg. So once the ADAM-TS13 is more than 20%, it is further tapered over a 3-week period and then stopped. So the next modality of treatment is rituximab. The important thing to note related to rituximab, it is added only after ADAM-TS13 is confirmed. That is, ADAM-TS13 deficiency is confirmed. So the mechanism of action is, it is a CD20 receptor acting MAB, that is a monoclonal antibody. So rituximab is a monoclonal antibody that binds to the cell surface protein CD20. This CD20 is widely expressed on the B cells, that is B lymphocytes. So what it does is, rituximab binds to the CD20 and eliminates B cells, that is B lymphocytes, through 3 mechanisms. One is antibody-mediated cellular toxicity. So what is it? Here the Ritux goes and binds to the CD20, forming an antigen-antibody complex. And with the natural killer cells coming in contact with it, it induces apoptosis. Second is direct apoptosis by binding to CD20 cell surface, that is direct killing. And complement-mediated cytotoxicity. So this Ritux CD20 complex attracts IgM and IgG antibodies. This causes triggering of the classical complement pathway by binding of the C1q protein. Now, don't worry about the complement pathway, because in atypical HUS, that is complemented TMA, in the pathogenesis, main emphasis is given related to the complement system. So I'll be discussing about it again in that area. So nothing to worry. So triggering the classic complement pathway lead to the formation of the membrane attack complex that leads to the cell lysis. So there were three mechanisms. One is antibody-mediated cellular toxicity, direct toxicity, and complement-mediated toxicity. So the dose goes as 375 milligrams per meter square IV once a week for 4 weeks after plasmapheresis, which should not be given in conjunction with plasmapheresis because it will be cleared during the plasma exchange process. And the fourth modality that's considered is taplacizumab. So how does it act? It's basically a von Willebrand factor directed mAb. So it targets the A1 domain of this von Willebrand factor, thereby preventing the interaction between the von Willebrand factor and the platelets. So this helps to decrease the formation of the microthrombi. So the dose is on the first day, that is the initial loading should be given as 11 milligrams IV at least 15 minutes prior to the plasma exchange. And following plasma exchange, another 11 milligrams should be given as subcutaneously. So thereafter, 11 milligrams is usually given post plasma exchange, and after the plasmapheresis course is completed, it is continued for 30 days from the last plasma exchange. So the dose is 11 milligrams IV is the initial loading. Thereafter, all are given as subcutaneous, and it has to be given post for plasmapheresis, and after plasmapheresis is over, it is given for a 30-day period. The current recommendations for its effectiveness now is only in severe manifestations. That is, if there is neurological or cardiac involvement, and TTP does not improve after 2 to 3 days of plasmapheresis and steroids. So in these kind of subsets, only caplacizumab has shown to be very effective. So as I mentioned, the mechanism of action for rituximab, once it binds to the CD20 receptor, three things can occur. One is antibody-mediated cellular toxicity, whereby it binds to the CD20 receptor, and the natural killer cell sees it and attacks it and destroys it. Then another thing is it can directly bind to the CD20 and destroy it completely, and there can be complement activation once it binds to the CD20, and that itself can lead to destruction of these B cells. So just for a summary, so ADAMTS13 deficiency can be replaced with plasma exchange. So that is why it is one of the main modalities, and has previously, as Niharika madam has spoken, in plasmapheresis. For TTP, the main goal of treatment is to replenish the ADAMTS stores, which can be replenished with use of plasma. And in congenital TTP, they say that you need to go with regular plasma supplementation in those subset of patients. Usually it goes lifelong. And immunomodulatory therapy is mainly targeted against these autoantibodies, that is steroids and rituximab. And von Willebrand factor mAbs like caplacizumab acts such that it helps to prevent the binding between the von Willebrand factor and the platelets, thereby preventing the formation of microthrombi. The rest of the treatment modalities I'll discuss subsequently. So we had discussed about the first line treatment and the relapse. The only difference between relapse and first line treatment is about the addition of caplacizumab. So coming to the exacerbation and refractory disease, usually in these subset, you go with plasma exchange with the intensification of the dose and the frequency. You go with higher plasma volume and you go with more frequent sessions. Plus you increase the dose of corticosteroids. Then you go ahead, you continue with rituximab. Then you can consider addition of cyclosporin. That's a dose of 3 milligram per kg, be 12th hourly, or cyclophosphamide 500 milligrams once a day. And the last resort is splenectomy, because it is shown to reduce the autoantibodies and the relapse-free survival is almost 70%. Now, if we had listened to the initial slides, I had mentioned about this drug, cyclosporin, because cyclosporin itself has been reported to cause secondary TMS. So, even though they mention it in treatment of exacerbations and refractory diseases, it should always be kept in mind that cyclosporin itself is a trigger for causing TMS. The next is treatment of supportive management. So one is platelet transfusions. It is only indicated in cases of clinically important bleeding and those who require invasive procedures. In cases where for venous thromboembolism prophylaxis, pharmacological is initiated if platelets is more than 50,000 and mechanical if it is less than 50,000. The important thing to note is thrombocytopenia here is not protective against thrombosis, as I mentioned in the pathophysiology. For RBC transfusions, we go with a restrictive strategy and management of complications related to plasmapheresis like fluid shifts, dyslipidemia, catheter-related or infections. And consultations, if manifestations are present, like if neuro manifestations are there, neurologist consult is mandatory, and a cardiac manifestations are there, a cardiologist consult is mandatory. So this is just another summary. So for autoantibody removal, immunomodulation therapy is the modality of choice. Choices are steroid, Rutux, cyclophosphamide, vincristine, splenectomy, and bortezomib. Bortezomib, though it is now not recommended in the guidelines, just for completion's sake, I will mention it. And if there is ADAMTS deficiency, that is deficient activity, then you have to supplement it with fresh fluorescent plasma. That can be done via plasmapheresis. And caplacizumab prevents the platelet and von Willebrand activity binding, thereby preventing microthrombi active formation. So the next and the last topic is about hemolytic uremic syndrome. So these will be the areas I'll be covering: the introduction, definition, etiology, pathophysiology, clinical evaluation, diagnosis, and management. So coming to the introduction, so originally TMA syndromes associated with AKI were recognized mostly in children only. So most common etiology in children was an enteric infection caused by Shigella toxin producing bacteria. Mostly Shigella dysentery and some strains of E. coli, such as E. coli strain 0157 is to H7. So the clinical presentation characteristically begins with several days of severe abdominal pain and diarrhea, which becomes overtly bloody. And as the diarrhea decreases, up to 15% develop AKA. So this disorder is hemolytic uremic syndrome, also called as Shiga toxin mediated HUS. However, after initial descriptions of HUS, some patients were described as having HUS without diarrhea itself, with persistent or recurrent disease or a family history of HUS. And these were described as an atypical hemolytic uremic syndrome. So coming to the definition, STHUS is reserved for disease caused by Shiga toxin. So the use of STHUS implies that recovery will occur spontaneously. Complement-mediated HUS or atypical, previously called as atypical HUS, is a term used for TMA with inherited pathogenic variants in complement genes or acquired autoantibodies against certain complement proteins. I repeat it, term used for TMAs with inherited pathogenic variants in complement genes or acquired autoantibodies against certain complement proteins. So coming to the etiology, STHUS is caused due to a Shiga toxin, also called as virotoxin or virocytotoxin, produced by Shigella dysentery or E. coli. So it usually binds to the glycolipid layer or the globotriacyl ceramide that is expressed in the kidney cells and produces injury. Under complement-mediated TMA, it can be because of pathogenic gene variants. in complement factor DHI or membrane cofactor protein or CD46 or complement factor 3. Or there can be autoantibodies against complement factor H. So for CTMA, the complement factor BHI, complement factor 3, and membrane cofactor protein. If there is any pathogenic variants that are present, or there are any autoantibodies against complement factor H, it can predispose to CMTMA. So before we go into the pathogenesis, what normally happens in the coagulation cascade is, in the complement cascade is, there are usually 3 pathways. One is the classical pathway, that is the antigen antibody complexes or on the pathogen surfaces. So that will attract immunoglobulins, and immunoglobulins will cause release of certain complements also, like C1q, C1r, C1s. C1q was what I mentioned in the previous slide, C4 and C2. So there is also a Mannan-lectin pathway that binds on the pathogen surfaces and releases these factors or complements. And there is an alternate pathway whereby from the pathogen surfaces, there will be chemokines that are released, and that causes activation of C3, complement B, and complement D. So ultimately, when all of these are activated in the circulation, they will cause activation of your C3, that is complement 3, via this complement convertase. So once it is activated, C3 causes A will cause inflammation and C3b will cause opsonization of these foreign bodies. So this C3 will also cause activation of C3b. So the C3b will cause conversion of C5 to C5a and C5b. The important thing to note is about C5b. Now, C5b is the initiator for this, initiating this membrane attack complex. So once this membrane attack complex is stimulated, it causes activation of the subsequent complements, that is C5b, 6, 7, and 8. So that causes a widespread inflammation during the process of destruction of these foreign bodies. So coming to pathophysiology related to ST-mediated HUS, there is, as I previously mentioned, release of sugar toxin, that is protein complexes, will bind to the glycolipid layer in the kidney cells. That will lead to endothelial injury and activation. Eventually, it will also cause inhibition of ADAMTS13 activity, increasing the von Willebrand factor multimers. There will also be activation of the complement system, leading to the formation of the membrane attack complex, that is C5b to C9. And there will be inhibition or downregulation of CD59 on the endothelial surface. The normal function of this is to suppress this membrane activation attack complex via inhibition of C9. So this sugar toxin will cause suppression of this CD59, which leads to unregulated complement activation, leading to inflammation, persistent inflammation. So with regards to the complement-mediated HUS, in order to achieve immune surveillance, the alternate pathway of complement system is constitutively active and inducible. That is, it has features that allows rapid amplification of necessary functions in addition to the classic pathway. So this reactivity necessitates precise regulation in order to limit inadvertent tissue injury. So the normal complement regulatory proteins include complement factor H, complement factor I, complement factor B, membrane cofactor protein, also called as CD46, preventing excessive or inappropriate activation of complements in host cells. Complement-mediated TMA occurs due to inherent pathogenic variants in the complement genes or due to autoantibodies targeted against the complement factors, that is, these regulatory proteins, especially factor H, leading to widespread membrane attack complex formation. So this will lead to platelet aggregation and formation of thrombosis because of endothelial injury. And that leads to uncontrolled platelet activation and consumption, leading to thrombocytopenia, reduced clotting ability, purpura. Widespread thrombi occluding the blood vessels leads to tissue damage and or necrosis. And formation of fibrin strands leads to cellular damage from fibrin deposits, leading to MAHA. So clinical evaluation, the predominant manifestations is presence of MAHA with thrombocytopenia and AKI if STHUS is present. So other manifestations are usually cardiac, whereby myocarditis can be present, manifesting as acute heart failure. Neurological, there can be acute altered mental status, coma, stroke. Endocrine, there can be impaired glucose tolerance. With regard to CMTMA, clues that can aid in diagnosis is family history of TMA, unexplained renal failure, or death during pregnancy. So for diagnosis, the basic workup is the same as for PTP. As I mentioned, you need to go for the complete blood count, LDH, then haptoglobin levels, peripheral smear. Then you need to do an organ-based assessment to look for any dysfunctions, and neuroimaging if there is any neurological involvement that is present, and serological testing. Additional testing in relation to HUS will be, one is to check for ADAM-TS levels. As in majority of cases, TTP will be a consideration. So activity level more than 10% is usually in favor of typical or CM-HUS. Then testing for sugar toxin producing organisms like stool cultures for E. coli or Shigella species, Shigella toxin assay, or DNA testing using PCR from stool sample. But the CDC recommendation is to go for stool culture and for sugar toxin assay. Then complement testing. Testing is very important in the setting of MAHA and thrombocytopenia with no alternate explanation for other diagnosis. And testing is important because it confirms the diagnosis and facilitates testing of the family members also. So you need to test for anti-complement factor H antibodies. Complement genes like factor HIV, membrane cofactor, and complement 3. So the genes, complement factor genes you need to remember are DHI3 and CD46 or membrane cofactor protein. And kidney biopsy may be performed in evaluation of unexplained AKI, may confirm the presence of TMA syndrome, but the problem is it does not help to identify the specific type of TMA. So it is usually done to assess the severity of ischemic injury, and it is also used to facilitate decision making with regards to the use of anti-complement therapy. So coming to the treatment, supportive measures, that is the mainstay of treatment in STHUS and part of treatment of complement-mediated HUS. One is hydration to maintain euvolemic status, antibiotics mainly for infections suspected at other sites other than kidney, avoidance of NSAIDs, RBC transfusions is more for restrictive strategy, platelet transfusions if it less than 50,000 or clinically significant bleed is present, and dialysis if anyone is present, refractory hyperkalemia, olipuric or anuric volume overload, uremic complications, or severe metabolic acidosis despite medical management. Then, with regard to therapeutic plasma exchange in STHUS, it has no role. There are multiple articles which have shown in STHUS there is no role for therapeutic plasma exchange. Please do not go ahead with that if at all STHUS is diagnosed. Whereas in complement-mediated TMA, it helps in resolution of extrarenal manifestations like MAHA, thrombocytopenia, renal resolution to a certain extent. But all these are based on observation studies only. There have not been any proven RCT. So management specific to CMTMA. So features supportive for CMTHUS. One is personal or family history of kidney disease not explained by another condition. Thrombocytopenia less than 10,000 or less than 50% for that patient. Presence of MAHA, AKI, ADAM-TS level more than 20% plus stool workup is negative for sugar toxin. and TMA with significant AKA that has been present during pregnancy. In all these subset of patients, there should be a high suspicion of CMHUS. So the important drugs for CMHUS, one is eculizumab. That is a map that is directed against C5 complement component, thereby inhibiting the membrane attack complex, thereby reducing inflammation. So it is given as an induction dose of 900 milligrams intravenously once weekly for 4 doses. Then the maintenance is initiated from week 5 at 1200, from 900 to 1200 at week 5 and thereafter every 2 weeks. The other drug, which is also a C5 mAb, a complement component targeting mAb, is rivalizumab. So its induction dose is 2700 IV once and maintenance is 3300 milligrams given every 8th week, starting 2 weeks after induction. So for induction for eculizumab, it is 900 and 1200. For ravalizumab, it is 2700 and 3300. So individuals treated with eculizumab or ravalizumab, the important thing to be done is the patient should be vaccinated against encapsulated organisms because you are hitting it hard on the complement factors. So for testing, just for revision point of view, for testing for inherent pathogenic genes in relation to complements, you look at complement factor PHI and you look at complement C3 and along with that membrane cofactor protein CD46. And antibodies against these complements is anti-complement complement factor H. If MABs are used during plasma exchange, the doses should be repeated after plasma exchange. That is also an important point to be noted. Thank you. So if any queries are there, let me know. I'll be happy to answer through messages.
So Srihari, can I take over?
Yes, you can take one.
Can you see my screen?
Yeah, it's usually.
So good evening. So we'll be dealing with hemophagocytosis, lymphohistiocytosis syndrome today. So what is HLH? It is a rare fatal disorder. It happens because of the dysregulated activation of cytotoxic T lymphocytes, natural killer cells, and macrophages. So which will lead to immune mediated injury of multiple organ systems. So basically there is hyperinflammation, there is hypercytokinemia and hyperinflammation leading to organ dysfunction. That is HLH. So HLH can be classified as primary HLH and secondary HLH. The primary HLH is because of the genetic causes which could cause dysfunction of the NK cells, cytotoxic T cells or control of those cells causing hyperinflammation. The secondary HLH is mainly because of any of the underlying conditions like cancer, cancer related therapeutic options, any infection, rheumatological diseases, which we will discuss further. So coming on to primary HLH. It is a form of familial HLH where it is usually associated with immunodeficiency disorders. So there will be genetic mutations in a homozygous or in a heterozygous pattern, which may cause disruptive mutations, which may fully eliminate the function of cytotoxic T cells and natural killer cells. And this usually present in the first year of life. Approximately 70 to 80% of the cases will manifest in the first year of life. More, it can even happen after first year of life also. So basically there is a genetic mutation which is causing the hyperinflammatory process. So this table shows us about the genes which are involved in the primary HLH. There could be multiple genes like PRF1, UNC13D, STX11, RAP27A, STXBP2, SH2D1A, ZAP and LIST. So these are all some of the genes which could be involved in the primary HLH causing the inflammatory syndrome. So if you see in this, whenever you suspect a primary HLH, we have to subject the patient to some of the assays. For example, if you see perforin and granzyme B protein expression is one of the tests which is used to diagnose the primary HLH. Basically, these are the proteins that are expressed in various cell types and thought to play a role in cell-mediated cytotoxicity. And the second one is the CD107A mobilization, where this expression is a marker of degranulation and cytotoxic activity in the cytotoxic T cells and natural killer cells. And SAP protein expression, which is nothing but SLAM associated protein, again an intracellular protein that is expressed in T cells and natural killer cells and some of the B cells. And then comes SAAP protein expression, which is nothing but X-linked inhibitor of apoptosis protein, which is a protein that is expressed in all human tissues except peripheral blood leukocytes. It is the key regulator of cell death and it is overexpressed in cancer cells. So these are some of the major investigations which we would do in primary HLH, and then genetic workup which will ultimately diagnose the primary HLH. Coming on to secondary HLH, as the name suggests, it is an acquired form. There could be any of the external trigger like infection, malignancy, any of the rheumatological diseases, post hematopoietic transplants, drug hypersensitivity. It could be any of this. If the HLH happens because of an autoimmune cause, it is called as macrophage activation syndrome. The other names for secondary HLH could be macrophage activation syndrome like syndrome, hyperferritinemic syndrome, viral associated hemophagocytic syndrome, sepsis HLH overlap syndrome. So these are the other names. Coming on to causes of secondary HLH, as I told you, it could be infection associated. Mostly it is viral infection, and among the viral, mostly it is Epstein-Barr virus. Okay, so viral infection, it could be EBV, it could be CMV, herpes virus, adenovirus, HIV, parvovirus, and measles virus. Bacteria, it could be Brucella, Rickettsia, Leptospira, Mycobacterium, Borrelia, Bartonella, Listeria, Mycoplasma, and Ehrlichia. Coming on to parasitic infection, yeah, leishmaniasis is one of the important causes. Other causes could be malaria, toxoplasma, and babesia. Fungi, candida, cryptococcus, penicillium, pneumocystis, and histoplasma. So I told you, when it is caused by an autoimmune cause, it is called as macrophage activation syndrome. It mainly happens in cases of systemic onset juvenile idiopathic arthritis, adult onset Still's disease, SLE, and vasculitis. And some of the transplant associated causes are immunological reaction at engraftment, GVHD. And some of the drugs causing secondary HLH, carbamazepine, phenobarbital, sulfamethoxazole, and cancer immunotherapy drugs. So malignancy associated, it could be hematological malignancies, primarily T cell lymphomas like peripheral T cell lymphoma, primary cutaneous T cell lymphoma, anaplastic large cell lymphoma, lymphoblastic lymphoma, angioimmunoblastic T cell lymphoma. B cell lymphomas is diffuse large B cell lymphomas. and B and T cell leukemias, NK cell lymphoma leukemias, Hodgkin's lymphoma, myeloid neoplasia, and others like Langhans cell histiocytosis, histiocytic sarcoma, multicentric Castleman disease, and solid tumors also. So what happens exactly in HLH? So there is failure of negative feedback loop that normally control the inflammation. So we know that because of the primary genetic reasons or because of the secondary susceptibility reasons, there could be underlying defect in the natural killer cells and cytotoxic T lymphocells. As I told you, because of the susceptibility, which may lead to failure to clear the antigen from the infected tumor or autoimmune cells and antigen presenting dendritic cells. So this will in turn trigger uncontrolled immune stimulation in an attempt to clear the pathogen, whatever it is, malignancy or infection or autoimmune cell. In an attempt to clear the cells, there will be uncontrolled immune stimulation with the activation and proliferation of the macrophages and cytotoxic T lymphocytes in a self-perpetuating fashion. So this will ultimately lead to a massive production of the cytokines, which will lead to cytokine storm and hypercytokinemia, resulting in hyperinflammation, where this inflammatory cytokines will cause end organ damage, and ultimately macrophages will start engulfing the RBCs, WBCs, platelets, and causing hemophagocytosis. So as I told you, because of genetic variants and background inflammation, there is individual susceptibility. So the trigger would be here, either it's a tumor or an autoimmune cell or an infection. So the trigger with an underlying susceptibility causes uncontrolled immune activation, causing release of the inflammatory mediators, ultimately leading to clinical manifestation, organ dysfunction, and hemophagocytosis. In a more detailed way, you can see that the natural killer cells and the cytotoxic T lymphocytes defects and the consequent deficiency in the perforin and granzyme secretion in genetically susceptible patients result in an extended lymphocyte and antigen presenting cell interaction, but an insufficient defense against the infectious and cancer, leading to generation of a lot of inflammatory cytokines like interleukin 1, 6, 18, 33, tumor necrosis factor alpha. Okay, so this cytotoxic T lymphocytes proliferation as a result of innate immune activation by infection, causing the prolongation of the interaction between the antigen presenting cells and the cytotoxic T lymphocytes, again leading to hyperinflammatory cytokine release. And in the third scenario, an intense pro-inflammatory response mediated by the macrophages may result from increased autoantibody and increased immune complex production, finally leading to phagocytosis and release of inflammatory cytokines. In case of malignancy and malignancy related this chimeric antigen receptor T cell therapy, these are nothing but genetically modified T cell therapy. There is release of perforin, granzymes and cytokines leading to cell death, which induces the pro-inflammatory substances causing secondary HLH. So these are the 4 scenarios explaining all the possible underlying causes of HLH, which ultimately lead to hyperinflammatory syndrome. Like in genetic deficiency, because of an infection, there is a overactivation of the cytotoxic lymphocytes. Because of again inflammation, auto antibodies and malignancy, there is activation of macrophages. And in general, malignancy and malignancy associated therapies, how it could trigger hyperinflammatory syndrome. So these are the 4 scenarios where there is hyperinflammation causing organ dysfunction. Now, let us go a little more detail in the secondary HLH, because primary though we know if that such patient comes to ICU, we'll have a documented diagnosis that yeah, the patient is primary HLH having a secondary infection coming to us, could be that way. But the secondary HLH, which is usually triggered by the infection related or in a malignancy patient who had received some therapy and eventually ending up in HLH, are the common causes, common patients which we usually see in the ICU. So that is why we'll just see a little more brief on secondary HLH and individual causes. So infection and secondary HLH. I told you EBV is the most common cause of secondary HLH among all the viral infections. It is usually seen in those susceptible patients, especially in malignancy patients, patients who have this gene mutations which is getting triggered during an event, and bacterial infections like approximately 9% contribute to the secondary HLH. And I told you parasitic infections like visceral leishmaniasis can cause secondary HLH. Coming on to malignancy and secondary HLH, it could be a direct result of malignancy, like mostly hematological malignancies and lymphomas, or it could be cancer treatment related, like chemotherapy related, hematopoietic stem cell transplant related, or novel immune therapies related, or solid organ transplant related. It could be cancer treatment related secondary HLH. Immune therapies like monoclonal antibodies, dendritic vaccines, checkpoint inhibitor, and chimeric antigen receptor T cell, which is the most common one, could cause secondary HLH. And some of the solid cancers can also cause secondary HLH, which is usually underdiagnosed. And this secondary HLH may be associated with other opportunistic infections also. And it may mimic GVHD, where hyperferritinemia could be one of the clue. Coming on to autoimmune diseases, as I told you, it is usually associated with systemic juvenile idiopathic arthritis. Sometimes it could be associated with adult onset Still's disease or SLE. It complicates the underlying vasculitis, and the triggers could be infection or a drug therapy for the autoimmune disease. Coming on to sepsis and HLH overlap. This is where we usually get confused whether to start therapy for it, because we have to subject the patient to many special tests to detect the HLH, whether the tests are available or not, whether we should clinically suspect an HLH with bicytopenia and start the treatment or not. It is very confusing. It is very difficult to differentiate the sepsis and the HLH because they usually overlap. All the clinical features and in laboratory investigations usually overlap. It could be called as a sepsis mimic also. So the secondary HLH triggered by infection predisposed to sepsis by inherent immune dysfunction, and there could be coexistent malignancy or an autoimmune condition which may worsen the confusion more. So secondary HLH should be suspected in all critically ill patients with unexplained fever, cytopenias, organ dysfunction, especially when they don't respond to that aggressive therapy of antibiotics and organ support. Even after that, if the cytopenias persist, then you should have a strong suspicion of HLH, because it is usually very lately diagnosed or underdiagnosed. So coming on to clinical features, this is in general, meaning for primary and secondary. It could be fever, which is the most common symptomatology, fever, but it may be absent in neonates. I'm mostly concentrating in the adults. Splenomegaly, which is seen in 40 to 87% of the patients. Hepatomegaly, which is seen in 14 to 71% of the patients. And neurological symptoms is very common, like 9 to 25% of the patients. Miscellaneous, in children, the order could be rashes, edema, lymphadenopathy, jaundice. In adult, it could be lymphadenopathy, rash, and pulmonary involvement. So this is a symptomatology which can be seen in the ICU and approach in the ICU. So fever, as I told you, it is one of the cardinal signs, almost always present at some stage of the disease process. It is classically persistent and non-remitting. Though recurrent fever pattern is possible, and it is typically unresponsive to antibiotics. Organomegaly, lymphadenopathy is not commonly seen. Splenomegaly and hepatomegaly can be seen more commonly in children. A strong association with lymphoma or viral infection. Splenomegaly is rarely observed in sepsis alone. So this raises a suspicion that it could be HLH. Okay. Organ dysfunction, which could be seen both in sepsis and HLH in ICU. But pulmonary manifestations are very common. Around 50% of the patients can have pulmonary manifestation, and it is usually a ARDS pattern where they may require mechanical ventilation. Cardiovascular manifestation could be from mild hypotension to profound shock requiring vasopressors. And HLH related cardiomyopathy is also described. And successful use of extracorporeal life support as a bridging therapy has been described. Renal impairment, it is well described. not consistently seen, and frequently absent in the early stages. Majority with AKI in the late stages will require renal replacement therapy. Significant proportion of survivors with long-term chronic renal impairment. And neurological dysfunction, this is the one which usually confuses us, like it could be a wide spectrum of presentation, like mild cognitive impairment to delirium, seizures, and coma, might signify that advanced stage of secondary HLH, and it is associated with very poor prognosis. And skin manifestations in up to 25% of a series of 775 adults with HLH, it is seen. 25% it is seen, and it could be ranging from rashes to erythroderma, petechiae, and generalized purpura can be seen. So this is the approach to symptomatology in ICU. This is the approach in general. Coming on to laboratory investigation. So as the name suggests, whether there is hemophagocytosis is there or not, that is the one of the named finding there in the disease. So what happens in the pathological finding? Macrophages engulf the mature or immature blood cells in the bone marrow and other reticuloendothelial organs. But this phagocytosis is neither pathognomic nor diagnostic for HLH. Okay. Where this hemophagocytosis could be seen in general sepsis and MODS patient itself. Approximately 60% of the patients with sepsis and MODS could have such finding of hemophagocytosis. Okay, so in a general HLH, there will be definitely accumulation of excessive lymphocytes and macrophages in the examined tissue, and it can be seen in the bone marrow. Not only that, it could be seen in spleen, lymph node, liver, skin, lung, meninges, CSF, and rarely in the subcutaneous tissue based on the organ dysfunction involved. So the bone marrow will be initially hypocellular. Later it becomes initially hypocellular, hypercellular, but later it becomes hypoplastic. That is why we see the cytopenias. And there could be hyperplasia of the histiocytes with florid hemophagocytosis, and additional findings like granulocytic and erythroid hypoplasia with variable megakaryocytic hyperplasia just to compensate the thrombocytopenia can be seen. And the adjacent marrow can show the features of the trigger process like a viral infection or a malignancy. Associated finding could be seen. But overall, this phagocytosis alone is not diagnostic or pathognomic of HLH. Okay. So this is one of the pictures showing engulfment of the blood cells by the macrophages. So coming on to the laboratory finding. So as I told you, there is cytopenia of more than 2 lines. Okay. It is seen in more than 85% of the adult patients in HLH. So anemia and thrombocytopenia are more common. Leukopenia is less common. Okay. Hypertriglyceridemia can be seen in 22 to 88% in adults. It is usually caused by the inflammatory cytokine tumor necrosis factor alpha, which in turn inhibits the lipoprotein lipase, causing hypertriglyceridemia. Hypofibrinogenemia can be seen in 24 to 93% of the patients, which is usually associated with poor prognosis. And ferritin, which is one of the important marker, seen in 77 to 100% of the patients. It has high negative predictive value in both children and adults. And elevated soluble CD25 levels as a marker of this natural killer cell cytotoxic T cells activities. 100 to 76 to 100% can be seen in adults. Levels more than 10,000 or a slow rate of decline is associated with poor prognosis. And the other findings could be hypoalbuminemia, which is seen in 80 to 90% of the patients, poor prognosis, associated with poor prognosis. Abnormal renal function, if there is an AKI, mostly in the end stages, these are all end stages involving all the organs, associated with poor prognosis. Elevated transaminases, along with hepatomegaly, if there is further hepatic damage, then there could be elevated enzymes is one of the diagnostic criteria in the H score. Hemophagocytosis, which could be seen in 53 to 100% of the patient, which is not sensitive, not specific to the diagnosis of HLH. And low or absent NK cell activity, which is seen in 20 to 80% of the patients, which has a predictive value for HLH prognosis. So that is in general. In case of an ICU approach, along with a proper history like a travel, drug, sexual family history, along with proper examination like lymphadenopathy, hepatosplenomegaly, rashes, bleeding, signs of organ dysfunction, we have to subject them to routine investigations along with special investigations like ferritin, triglyceride, CRP, and the transaminases and coagulation screening, and organ screening like CT, ultrasound screening, and infectious disease workup. What all I told you as an infectious cause, it could be, we have to subject them to routine cultures, HIV screening, hepatitis screening, EBV, CMV, PCRs, parvovirus, parasitology screening, fungal screen cultures, even tuberculosis we have to rule out in case of a secondary HLH, and malignancy workup, as in take a hematology consult, bone marrow examination, and autoimmune workup like an autoimmune screen. And if suppose there is specific organ dysfunction, then subject them to CSF analysis, MRI brain, PET scan, tissue sampling. If finally there is genetic testing also, if all other diagnosis is ruled out. So this is in case of an approach in ICU as a secondary HLH. So why do these laboratory findings happen in HLH? Why do the cytopenia happen? It is because of the high level of inflammatory mediators act on the precursor cells in the bone marrow to suppress the hematopoiesis and induce apoptosis of these cells. Why do the ferritin go up? It is because of the upregulation of the heme oxygenase, which is a heat shock protein expressed in response to an inflammatory cytokine, which is acute phase reactant. CD25. It is one of the IL-2 receptor alpha chain marker of activated lymphocytes. Activated lymphocytes release the soluble form of CD25, which is what we measure usually in the lab. Natural cell activity, measure of the ability of the natural killer cells to degranulate and kill the target cells. That is why we measure that activity to see how effective it is. And DC163, which is a macrophage specific scavenger receptor for native and chemically modified hemoglobin. Hypertriglyceridemia, why does it happen? It is because of the lipoprotein lipase activity because of the tumor necrosis factor alpha levels. Hypofibrinogenemia, why does it happen? Macrophage activation leads to increased fibrinolysis, resulting in elevated D-dimer levels and decreased fibrinogen levels. Coming on to approach to HLH. So whenever a patient is having cytopenia and hepatosplenomegaly, or there is any other organ involvement as we described before, if yes, then subject them to the diagnostic workup. As I told you, routine investigation along with special investigation. And if you suspect any underlying genetic cause, then subject them to the underlying genetic cause like specific assays for the natural killer and cytotoxic NK activity. And to rule out organ dysfunction or any viral infection, bacterial infection, parasitic infection related organ dysfunction, you see the imaging studies. That is how you go. If you find it is an HLH, then subject them to genetic testing for sure, and monitor them with daily routine CBCs, liver monitoring, and you can do weekly monitoring of CD25 and ferritin. Because from a higher level to a lower level of ferritin can tell us the responsiveness to the treatment. So this is in general for primary and secondary HLH. In ICU, whenever a patient is having fever, cytopenia, organ dysfunction, first you check the serum ferritin level. If it is less than 500 microgram per liter, then as I told you, it has a very high negative predictive value, then less likely it is an HLH. If you still feel the patient is worsening, you repeat the ferritin after 1 or 2 days, or when the patient is worsening more. Then if the ferritin levels are between 500 to 10,000, then highly likely it could be HLH. Then subject them to other diagnostic parameters of HLH, like you can use a diagnostic score like a 2004 score or H score, or you can do other tests like fibrinogen, triglycerides, and LDH values. So based on that you diagnose and treat. But if the ferritin levels are more than 10,000, then the chances of HLH is very highly likely. You start treatment immediately. Coming on to clinical scoring. So we have so many scores, like because we know it is caused by primary, secondary, autoimmune causes. So based on the etiology, there are many scores, but the commonly used ones are HLS 2004 and head score. Okay, HLS 2004 we'll discuss next. It is derived, there was a score from HLH 94 formed by the Histocyte Society, and later it is modified in 2004, which is still running. And the head score is a web-based online calculator involving 9 criteria like immunosuppression, fever, organomegaly, like elevated triglyceride level, ferritin level, AST/ALT levels, and fibrinogen levels, cytopenias, hemophagocytosis in the bone marrow, etc. Like there are many criteria, and each criteria is given a score. The score ranges from 0 to 337. Higher the score, higher the probability of HLH. An optimal cutoff of 169, which corresponds to the sensitivity of 93% and the specificity of 86% in diagnosing the HLH. It is better than HLH 2004, we'll see why, and the sensitivity and specificity is better in pediatric population. So these two are the common scores which is usually used. Like HLH is a very important question because it has been recently asked in theory papers where the diagnostic criteria and the pathophysiology, primary secondary causes, you should at least know 2004 and H score. So this is the expansion of the 2004 score, wherein the diagnosis of HLH can be established if either 1 or 2 below criteria are fulfilled. Number 1, a molecular diagnosis consistent with HLH, and a diagnostic criteria for HLH. What are they? Fever, splenomegaly, hepatomegaly, cytopenia, affecting more than or equal to 2 cell lineages in the peripheral blood, like hemoglobin could be less than 9, platelet could be less than 1 lakh, neutrophil could be less than 1000. And whether there is hypertriglyceridemia or hypofibrinogenemia. What is hypertriglyceridemia? If it is more than or equal to 265 milligram per deciliter, and fibrinogen is less than or equal to 1.5 gram per liter. And if there is hemophagocytosis in bone marrow, spleen or lymph node, low or absent natural killer cell activity, ferritin more than 500, soluble CD25 more than 2400, and supportive clinical criteria like organ involvement, neurological symptoms, cerebrospinal fluid pleocytosis, conjugated hyperbilirubinemia, transaminitis, hypoalbuminemia, and hyponatremia. These are some of the supportive criteria. So as I told you, there are many scores. Like for example, in autoimmune causes, there is a mass JSLE score, and there is a modified EULAR score is there, and there is an MS score. So these are all according to the autoimmune causes. But what we commonly follow is 2004. But a head score is better because the common manifestations like the hepatic involvement is being included into the study. So as I told you, in 2004, there is fever, hyperferritinemia, hypertriglyceridemia, fibrinogenemia, cytopenia, NK cell activity, CD25 activity, and splenomegaly, and hemophagocytosis found in bone marrow or spleen. So presence of genetic mutations or 5 or 8 criteria met, then it is highly probable that the patient is having HLH. Coming on to head score, again all of these are there. Along with that, additionally, there is hepatic involvement. Hepatosplenomegaly ke liye there is transaminitis elevation. Based on that, additional organ involvement has been included. I told you more than or equal to 169 has a better sensitivity probability of diagnosing HLH. And in autoimmune causes, of course, the rashes are being especially involved, and the hemorrhagic manifestations, the central nervous system manifestations are being involved. So this is mainly related to the autoimmune causes. So whether this scoring system, whether it really helps us to diagnose HLH and treat the patients with HLH in ICU very fast, because already the patient is in cytopenia with hyperinflammatory syndrome and there is organ dysfunction. This 2004 score does not include major organ involvement like liver, central nervous system, no. And head score also does not include many systems, only the hepatosplenomegaly it has included as a difference from the 2004 score. So this these scoring systems are developed because of the clinical trials, where they included patients based on this criteria and they subjected them to treatment to see an outcome. But whether these criteria help us to really diagnose HLH in a critically ill patient, make us help create a treatment protocol for them, and early treatment, early improvement, does that really happen? So what are the diagnostic challenges with the current HLH criteria? We know that the HLH could manifest as two forms. One is immune activation. Because of some underlying etiology, there is immune activation. Ultimately, there is an immune mediated pathology like an organ dysfunction, cytopenia, because of the hyperinflammation. So usually this HLH and inflammatory condition, in HLH there is paradoxical finding. Because of the hyperinflammatory state, there is cytopenia, there is thrombocytopenia despite inflammation. And the existing diagnostic criteria, they have been developed for research trials and they are very limited and they do not completely include all the clinical and lab features of HLH. So there is delay in diagnosis because HLH itself is a rare disease, and the complex criteria and overlapping symptoms could confuse the diagnosis and treatment. So the issues with the current diagnostic criteria are the liver involvement is common, but the transaminase elevations are not included in 2004. Neurological symptoms are also common, but both the criteria does not include any neurological criteria. Immune activation markers such as ferritin, soluble CD25 often rise before the clinical deterioration only, not on the beginning of the process. So molecular diagnostics are becoming more available. So why not use it before earlier so that we can classify them and treat accordingly. So overall, a newer diagnostic framework could help us easily pick up the HLH and treat. Okay, so a future HLH criteria is definitely needed for early diagnosis and early treatment. So this is one of the, when I was looking for the HLH review articles, one of the review article had given a very sensible approach to HLH. Like you suspect a patient with a susceptibility that this patient could have HLH based on the category 1 findings. And once you suspect, you enter into the category 2, where you see, look for the markers of significant immune activation. And finally, you just see whether this, because of the hyperinflammation, the end organ involvements are there. It is more or less the same, but some of the new genetic markers which are now rapidly available, maybe not in India, I'm not very sure. I have also not heard of this rapid testing for genetic markers and all, but we have never done that. But it could be useful in early diagnosis to categorize the patient. For example, when you are looking at the category 1, you are seeing that along with the NK cell activity, CD25 activity, we can subject them for genetic defects of cytotoxicity. You can ask for any family history of HLH is there or not, or prior episodes of HLH is there or not, or unexplained cytopenias were there or not. And other assays like perforin assay, SAP assay, XIAP assay, and CD107A assay could be done so that we can diagnose the underlying immunodeficiency. And once the inflammation starts, along with fever, splenomegaly, hepatomegaly, ferritin, C25, we can also include a CD163, which I explained you before, for what reasons could indicate HLH as an approach. And finally, with the end organ dysfunction, not only localized only to cytopenia and triglyceride fibrinogen, other organ involvement like hepatitis, CNS involvement, what are all the common organ involvement, if those are also included into the diagnostic criteria, then HLH could be easily diagnosed, maybe easily treated for a better outcome. Coming on to macrophage activation syndrome, I told you it is a terminology, nothing but an HLH used in an autoimmune disease. But here, the only difference is there could be leukocytosis and thrombocytosis. Again here, this 2004 criteria does not include the leukocytosis or thrombocytosis. It usually says there is a cytopenia. So chances that we could miss this macrophage activation syndrome in a patient with an underlying autoimmune disease, right? So increased inflammation could cause increased fibrinogen levels, which is again misleading factor with the HLH 2004 criteria. So that is why other criteria were created for this specific autoimmune diseases. Coming on to differential diagnosis, what all I told as a cause for secondary HLH is all a differential diagnosis for HLH, specifically sepsis, where it is very difficult to differentiate those patients whether they have sepsis or really HLH. So sepsis, viral, parasitic, bacterial infection, drug reactions, storage disorders, Langerhans cell histiocytosis, Castleman disease are all differential diagnoses for HLH. So coming on to treatment, this is an approach basically for the secondary HLH, because primary, it is just, we have HLH Histocyte Society guideline which we follow, but in sepsis or in critically ill, there are many underlying factors which has to be controlled, like organ dysfunction has to be supported, early diagnosis should be there, early treatment should be started, all the multidisciplinary team should be involved. So this approach is mainly for the ICU and critically ill patients. So early diagnosis is the primary goal, supportive care and multiple organ support is the goal, and rapid initiation of specific HLH therapy to control the cytokine storm so that we are preventing the organ dysfunction, and identifying and treatment of any underlying trigger, mostly in ICU it is sepsis or malignancy or an autoimmune cause, and early involvement of an HLH expert or a multidisciplinary team to address the issue so that advanced treatment therapies can be planned. So once we diagnose and treat, if it the common protocol which we follow is the 1994 or 2004 protocol. Currently it is 2000 protocol, where in 1994 this was the first international treatment protocol for HLH, and the Histocyte Society had formed this in the year of 1994, where there was a survival of 55% with a median follow-up of 3.1 years with this treatment protocol. So what does it involve? There is an 8-week induction therapy with dexamethasone, etoposide, and intrathecal methotrexate. And the principal goal of induction therapy is to control the cytokine storm, the life-threatening inflammatory process that underlies the HLH. Then after the 8 weeks, there is a continuation therapy, which is either the intensive phase is weaned off, or it is transition to a continuation therapy, which is usually an indented bridge to the transplantation. Okay. Sorry. Yeah, so this is a chart showing us the 1994 protocol, where the initial intensive therapy was dexamethasone, etoposide, and intrathecal methotrexate, and there is a continuation phase also. Okay. Now, after 1994, there was one more protocol in 2004. What was different with from 1994? There is also an initiation of cyclosporin A at the beginning of the initial phase of treatment to oppose the action of interferon and achieve better immunosuppression. And it also proposes performing hematopoietic stem cell transplant as soon as possible, as soon as the donor is available. And along with intrathecal methotrexate, administering intrathecal prednisolone can prevent further progression of the neurological symptoms. So with all these changes in 2004, there was a decrease in mortality from 27% to 19% with the 2004 protocol, but overall mortality at 5 years were not different. So as I told you, along with steroid, etoposide, there is also cyclosporin A, and intrathecal therapy is with methotrexate and steroid, and there is a continuation phase. Coming on to salvage therapy, if all of these fails, even with intensive therapy, continuation therapy, if that fails, if there is refractory HLH, then other chemotherapeutic agents like cyclophosphamide, doxorubicin, vincristine, prednisolone can be added along with etoposide, and anti-CD52 antibody named alemtuzumab can be added, and cytokine adsorption using filter columns or a plasma exchange can be tried, and off-label treatment with JAK2 inhibitor like ruxolitinib can be tried. An anti-interferon antibody like imapalumab can be tried, and always there is hematopoietic stem cell transplant which could help. So this is in general, when a patient is having either primary or secondary HLH, whatever treatment protocol we saw, it is Histocyte Society. But what could be the approach in ICU? Because a patient could be already on steroids for refractory septic shock. So what could be the better approach in ICU? Like what we could add extra along with whatever Histocyte Society protocol says. Yeah, so we know that the steroids are the usual mainstay treatment for initial immunosuppression. If suppose the patient is already in a sepsis dose steroids, such as hydrocortisone 50 mg Q6 hourly, then it can be converted to a high dose pulsed methylprednisolone. It can be tried. But if the patient is having already neurological symptom, then dexamethasone could be one of the best options. Okay. And if suppose it is a malignancy related secondary HLH, for example, a lymphoma, some lymphomas could be very steroid sensitive. So before diagnosing this lymphomas, if we give steroid, then we may miss the diagnosis of lymphoma. So in such cases, if steroid treatment is already in the maximum dose, or if such cases, then anakinra can be tried, which is nothing but a recombinant interleukin 1 receptor antagonist, and it is very effective in controlling the initial cytokine storm in secondary HLH. So there was one study which I will show you later, where they tried this immunosuppressant therapy in sepsis. Okay, where they found that in patients with HLH and macrophage activation syndrome, as equivalent efficacy as steroids, anakinra had given a better positive outcomes, so which can be tried in the ICU in patients related to sepsis related HLH or mass. Okay, so it is well tolerated. Anakinra is well tolerated, has a favorable side effect profile, and it can be considered as a early treatment modality for HLH. But the financial cost could be moderate, and local availability is another problem. It can be given subcutaneously. It can be given intravenously, especially in very unstable ICU patients. It can be given intravenously. A higher dose can be started so that the effect could be better in very sick patients, and it has a shorter half-life, so it can be administered in split doses or as in continuous infusion. Okay, so anakinra can be started at a dose of 1 to 2 milligram per kg per dose, 12th hourly subcutaneously. You can increase up to 8 mg per kg per day. Okay, that is why in patients who are already on steroids or maximum dose of steroids, anakinra could be a better preferred choice. You can start with higher dose, as I told you. You can also give IV in case of very sick patients. The next choice would be methylprednisolone. I told you if the patient is on sepsis dose, then increase them to a higher pulsed dose therapy of methylprednisolone, like 30 mg per kg per dose for 3 days. Okay, and intravenous immunoglobulin can also be tried. It is started as 2 gram per kg per dose over 1 to 2 days. Consider repeat dosing after 2 weeks. Okay, and second line could be etoposide. Etoposide, as we all know, it is a cytotoxic agent, particularly against the macrophages and cytotoxic T cells. It is considered as second line therapy, and if suppose this inflammatory things does not work, the pulse dose does not work as a third line, you can use etoposide, and hematologist should be involved into the picture. It is mainly used for malignancy related secondary HLH, and dose reduction is required in the renal in liver impairment. Okay, and maintenance, we can try cyclosporin 1 to 2 mg per kg per day enterally or IV, then titrated to a target level as a second line treatment in some patients. And other important parallel treatment should be, especially in a critically ill patient in sepsis related to viral infections or the leishmaniasis or because of the infections, then antimicrobial therapy is a major role in case of bacterial infections. Rituximab can be tried for EBV driven lymphoproliferative disease. Heart should be started for HIV associated therapies, and targeted cancer chemo and biological therapy should be started for malignancies. So first line in ICU, we could choose anakinra, which has a better safety profile, or commonly what we use is steroid. We usually start with, in our ICUs, we usually start with steroids, and then IVIG we do use, but as in the later stage. But steroid, etoposide and IVIG is the usual algorithm we follow. So overall, an approach, whenever you suspect HLH, you subject them to the diagnostic criteria, If there is a positive HLH, then start with HLH 94 or 2004 protocol and continue intensive phase and maintenance phase. Okay. But if it is related to autoimmune diseases or malignancy diseases, if they are clinically stable, start with corticosteroids and then continue with maintenance phase, or finally hematopoietic stem cell transplant. But if there is infection or underlying EBV, leishmaniasis, then treat the underlying cause. If it is a malignancy, start with biological and chemotherapy for the malignancy. That is how it goes. If possible, always do a genetic testing. Again, I could not maximize this flow chart bigger because the clarity was bad. So I will try to read it out. So whenever there is an HLH in an adult patient, if the patient is clinically stable, try to identify the trigger for the suspicion of HLH. And if the patient is deteriorating, very unstable, then start with HLH 94 protocol if it is a primary genetic reason. Okay. If it is a secondary genetic reason, patient is unstable, then you look for the underlying infection, EBV related, start with steroids, rituximab. If it is a infection related to leishmaniasis, along with steroids, etoposide, you start with liposomal amphotericin B, because these are all very important, because of which the hyperinflammation is happening, right? If you could not find out any specific infection, but still there is a suspicion of sepsis, starts with corticosteroid, IVIG, so that it could at least reduce the inflammatory process. If it is a malignancy related, if it happens during chemotherapy or chemotherapy related HLH, then try with corticosteroids, IVIG. If it is malignancy triggered HLH, then you start with corticosteroids. As I told you, etoposide is usually used in malignancy related, and involve the multidisciplinary team. And other salvage therapies which we saw in the slide can be tried, like this alemtuzumab or imalpalumab can be tried, CHOP regimens can be tried, plasma exchange can be tried, but ultimately refer them for the transplant. And if it is because of autoimmune causes, then high dose methylprednisolone could be a better choice. And along with that, you can try etoposide if it is refractory. Drug induced, remove the causing drug, and you can start with tocilizumab, corticosteroids, and consider etoposide as a refractory therapy. And any other causes, like you could not find out what it is, but there is a HLH picture, then you without fail you start them with corticosteroids, and if needed IVIG, and if it is refractory, start with etoposide. So overall conclusion is, if there is an infection, treat. For example, EBV, rituximab, leishmania, liposomal, and if it is malignancy related, in very early only start with etoposide. If not, you start with corticosteroids, high doses. If anakinra is available, start with anakinra, and add etoposide as a third line therapy if both the things are not working. Okay. Coming on to outcome and prognosis. So whenever HLH is associated with a malignancy, it has a very bad prognosis, approximately 80% mortality. In ICU, HLH can lead to 52 to 68% of mortality. Not achieving a minimum of a stable and a partial response to treatment at 8 weeks is a very bad sign. And HLH, because of the EBV, age more than 45 years, or if the patient is having repeated evaluation showing hyperferritinemia, persistent thrombocytopenia, then these are all bad prognosis for HLH. So future, when there are some review articles which is telling that there are many monoclonal antibodies which has been in trial against the inflammatory cytokines, and gene therapy specifically targeting some of the genes can be applied in future for primary HLH. And this was the trial I was telling you, the PROVIDE trial, where it is mainly a randomized clinical trial introduced in immune classification system in sepsis patients, dividing them into 3 groups, like immunoparalyzed, intermediate group, and hyperinflammatory group. Okay, where in this trial, in the hyperinflammatory group, where the ferritin was very high, like more than 4,000, they were treated with anakinra. Okay, and they found that the overall outcome at 7 days were better. Okay, so that is why, if suppose steroid is one problematic issue, then anakinra can be tried as a better effective therapy for HLH. So this completes our talk. So next week would be toxicology. We will share the articles as soon as possible. We'll see next week then. Thank you.